Hello.
Good morning, everybody. On behalf of the Department of Pharmacology, I extend a warm welcome to all the distinguished faculty, esteemed colleagues, faculty members, and delegates to today's CME on occasion of 5th National Pharmacovigilance Week 2025. I request all the distinguished dignitaries to come on stage. First, Dr. Rajan Kaya, sir, Dean and Medical Director. Next, Dr. Girish Hongal, our Medical Superintendent. Next, our Vice Principal, sir, Dr. Anand Reddy. Next, our distinguished speakers, Dr. Aravind, who is the Deputy Medical Superintendent of Super Specialty Hospital. Next, Dr. Deepak Anand, sir, our Medical Superintendent of St. Peter's Medical College. Next, Dr. Siddhalingaya, sir, our distinguished speaker. Next, Dr. Raghu, sir, our HOD and Professor of the Pharmacology Department. Sujata, ma'am, Professor and organizing co-chairman of the Okay, now we begin with Tamirtai Varta. I request all of you to please rise.
But oh, you are seeing me today. Okay. I wanted to taste online. Yeah. Yeah, man. Sure, man.
Navratri inspires us to cultivate vigilance, discipline, and awareness in every aspect of the life. So, in the same spirit, our CME focuses on PV, the science of monitoring, detecting, and preventing adverse events of medicine. With rapid advances in therapeutics, from innovative drugs to complex biologicals, vaccines, PV has become a cornerstone of modern medicine. It safeguards us not only at individual patients but also public health, while reinforcing trust between healthcare professionals and society. So, as we begin today's session, let us carry forward the message of awareness, responsibility, and protection, values that beautifully unite the spirit of Navaratri by lighting the lamp. I please request all dignitaries to light the lamp.
Good morning, one and all who are present here. Respected dignitaries on the dais, professors and faculty, my dear students, I am privileged and honored to be present here before you on the occasion of CME commemorating the National Pharmacovigilance Week. So, as you all of you know, that pharmacovigilance plays a very important role in the patient safety in any healthcare system. So errors can happen during manufacturing, during prescription, and during dispensing. So it has a very important role to ensure the patient safety. I hope this CME will throw a limelight on this subject, and it will enrich the knowledge about the pharmacovigilance. I congratulate the team of pharmacology department under the leadership of Dr. Raghu, who has planned the CME, and I have gone through the topics. They have coined the terms very nicely, and very good speakers are there, and guest speakers are also there. My regards to all of them. My best wishes for the success of this program. Thank you.
Thank you, sir. That was very enlightening. So, The National Pharmacovigilance Week started on 17th of this month. So it is 17th to 23rd September 2025. We started with a walkathon on 17th September to create awareness among the healthcare workers and patients. On the same day, we conducted an awareness campaign in coordination with the Department of Community Medicine in the PHCs to create awareness among the patients. Then on 18th, we held a webinar cum hands-on workshop for the staff nurses on how to report ADRs to AMC, that is ADR Monitoring Center. Then on 19th, another batch of staff nurses for same session was conducted for on how to report the ADRs to the AMC. On 28th, we conducted a quiz competition, Spark 25, for the third year students. So we would like to distribute the prizes today to these students. So I request our Dean sir to please give the medals to the team that came first. Rohit Varshan, Netaji, Vijay Sagar. Next, I request MS sir to give the prize to the second place holders. Pooja, Sharmila, and Preeti. MS sir. Now I request our Vice Principal, Dr. Anand Reddy sir, to give away the prizes to the third place holders. Lokeshwari, Sanjana, Revati. Thank you, everybody. Now I would request to the dignitaries to alight the stage and please take the front row seats. So now we'll continue with our session. Our next speaker is Dr. Arvind S., Associate Professor of Pediatrics and Deputy Medical Superintendent at St. Peter's Medical College. He holds MD, DNB, MRCP, and FRCP degrees and completed a clinical fellowship and PICU at Great Ormond Street Hospital, London. A gold medalist and recipient of Rajappa Award for Best Outgoing DBS student, Dr. Arvind has published over 12 international papers and authored two book chapters. His interests include pediatric and neonatal intensive care. Today, he'll be talking on the topic of safe antibiotic use in children. Welcome, sir.
So, good morning, everyone. Uh, First, regards to the respected Dean, MS Sir, Vice Principal Sir, HOD of Pharmacology, senior faculty members, and the entire Department of Pharmacology. Big regards for organizing such a great week full of events. And thanks a lot for giving me this opportunity to talk here. So my talk will be entirely focused on the students, especially those who are occupying the 150th row in this hall. Uh, my professor used to say that the distance between the teacher and the student is directly proportional to the interest. My experience has disproved me several times. So I hope that wall in the last end is intact. At least some of you might try to get beyond that also. But don't worry, I'll engage you. There are lots of questions here, so we'll have a nice time. Yeah, that sound is good beginning. So I'm a pediatrician, as most of you might know. These are some of the calls I receive, um, mostly from my patients, sometimes from my colleagues, sometimes from people I don't recognize at all. So my child has a high grade fever. What antibiotic should I give him? The question previously used to be, so what do I do? Child has fever. Nowadays, they have decided they want to give an antibiotic. And the only question that I get is, what antibiotic should I choose? And then the second question is, my baby is coughing incessantly. Throughout night, he coughed, sir. So what antibiotic should I give? Other question is like, my child is too, when I suggest like, can we go for tests first and then try to find out what infection your child has? Many of them come up with the explanation, no, no, my child is very sensitive for blood tests. He will start crying. Like, I've yet to meet a child who doesn't cry with blood tests. So apparently some people feel only their children cry. Um, and the more important question is those who go abroad, like US, UK, they know that they cannot buy over-the-counter antibiotics there. So they want a list of antibiotics prescribed with my designation and stamp, so that it was unintentional. So they want me to prescribe the antibiotics, a big list, so that I have a qualification from UK. So somebody sees my name and designation, they don't respect me. So probably that was the intention. And the last question is one of the most difficult ones. They call me saying, "Sir, tomorrow my daughter is having her quarterly exam. Today she is having a fever. Give me something so that it immediately is resolved." So these are the questions I usually receive over the phone. So I'll take you through this talk. I hope at the end of this talk, most of you will be able to answer these questions for yours. So right now, we need to first understand the problem. How big is this magnitude of this problem of antibiotic use? Yeah, antibiotic. Let me tell you a disclaimer. I'm not against antibiotics. I'm only for its appropriate use. You all have a knife in your kitchen, right? It is used on a daily basis by you, your mother, your father, anybody who cooks at home. But you know how it can be misused as well, right? So antibiotics are something similar. They are extremely essential. They have saved millions of lives all around the globe, but they're one of the most commonly abused and misused class of medication. So how big is the problem that we are dealing with? This is one of the statements from Centers for Disease Control, which it is a official health-related body in the United States. So according to them, 1 in 3 antibiotic prescriptions are unnecessary. So you can imagine if Americans say 1 in 3 of their prescriptions are unnecessary, in India probably it's 4 out of 3. So it's something similar. You see, 70% of prescriptions are reasonably okay. 30% are unnecessary prescriptions. So they are actually advocating um, to improve antibiotic use to combat antibiotic resistance. So that is from the United States. So let's come to what is happening in India. So the most common group of infections, maybe in children and in adults, would be respiratory as well as gastrointestinal, right? Especially respiratory. That's one of the commonest group of infections. This is a cross-sectional study from India among under 3-year-old children presenting with acute respiratory infections. So you can see the frequency of antibiotic use across India. If you see northern and southern India, as usual, we top the list in use of antibiotics. So when I say use of antibiotics, I'm just trying to be nice because I'm also one of the clinicians. It is actually abuse of antibiotics. You can see that 1/4 of under 3-year-old children presenting with respiratory infections are being prescribed antibiotics. That is definitely not justified. That is quite excessive, indiscriminate use of antibiotics. I can see the eastern and western parts are a little bit better compared to the southern and northern ones. So what does this lead to? When you use antibiotics indiscriminately, it leads to antibiotic resistance, right? So this is being described as a silent pandemic within the pandemic. So this is an excellent paper published in 2022, where they call the evolution of antimicrobial resistance as a significant public health concern in India. Resistance to the drugs is not just restricted to some old categories of drugs like penicillin or macrolides, which were discovered few decades ago, but they are also increasingly being involving the newer and more expensive drugs like carbapenem, like for example meropenem, colistin. These are all the more sophisticated groups of antibiotics that we are using for resistant infections in the ICU. But increasingly, we are also witnessing resistance to these antibiotics, which is very alarming and very concerning. So available data indicate rising rates of AMR across multiple pathogens of clinical importance. So that is very difficult for us. Now, having understood the problem, let us deal a little bit with the social determinants of antibiotic misuse. This is a qualitative study conducted in Haryana in 2017 among the community members. So this is one of the uh, wordings from the people who distribute drugs. The reason why I'm not saying pharmacist is because who all are capable of distributing drugs in India. The corner pharmacy in the place where I used to live in Chennai, the pharmacy is usually manned by the son of the pharmacist. He's probably around 10 to 12-year-old. I mean, they think that he is capable of vending drugs. I'm sure many of you would have seen small kids working in pharmacy covering for their parents. It is not very uncommon. So many people who dispense drugs in India, in Haryana, in that study felt that prior work experience under a pharmacist's supervision was an adequate substitute for formal training. So I'm a pediatrician. I attend a lot of cesarean sections to take care of the baby. Imagine I claim after attending 50 cesarean sections, I've seen a lot of cesarean. Now today I'm going to try doing a cesarean section. It is something similar. It's very dangerous. You cannot just observe somebody doing something and start doing it yourself. That's not the right way to do. 85% of employees told abbreviated antibiotic courses, often just 1 to 2 days of tablets. This is also very common. Probably some of you would have had this personal experience. When you go to a nearby pharmacy, you say that the child in my home has fever, cough, cold. They will give you some medication. They will say take this for 2 days. Unfortunately, one of them will be an antibiotic like amoxicillin clavulanate. That's a disaster. That's a disaster in the making. Just because you don't see that adverse impact immediately, you shouldn't undermine the impact of those, which I'll be dealing with subsequently. So those are about the people who dispense the drugs. These are the general public perceptions. What do they think? They think antibiotic is a medicine one can take in any disease. It will not harm. You have a headache, you can take antibiotic. You have abdominal pain, you can take antibiotic. Secondly, an antibiotic is a drug that will not create any problem in our bodies. Absolutely untrue. I will deal with this subsequently in a few more slides. Antibiotics are drugs that will not cause any reaction, side effect. A while ago, I don't know how many of you had the opportunity to listen closely to Madam's talk. It was extraordinary. It was really good, detailing the basics of adverse effects of drugs. So those are very real. We do come across those on a daily basis. Unfortunately, many of them are not recognized. Those few that are recognized are also not reported appropriately by clinics. This is the reality in India. In pharmacy, you have med plus, you have med minus, you have multiplication, subtraction, addition, anything. You have lots of offers. It's almost like RD sale. You can have multiple courses of antibiotics at a discounted rate. Here there is 30% compared to 25% there. So you go there, stock all the medicines at home, just in case in the night somebody develops fever. That is a very bad practice as a country. Uh, you can see that nearby there is a yoga center where nobody bothers to go because that is preventive health and you don't see the impact immediately, so nobody bothers. This antibiotic resistance is not restricted to adults. It's not restricted to long course of antibiotics. We start messing up from the day of birth. So this is the data from neonates. See, 1 million Indian children die in the first 4 weeks of life each year. That is the problem with neonatal care and probably perinatal care in India. But among those deaths, 190,000, that is approximately around 20% of those deaths are caused by sepsis, bacterial infection that overtakes the bloodstream. Among those septic newborns who die, you can see that about 58,000 or just about 30% of them are due to antimicrobial resistance. It's a huge, alarming number, very huge. And I'm really scared to review these numbers when you all begin to practice and you stand on this stage. So it's a very alarming problem. The reason I'm addressing this to the students is please do not continue the same pattern. It should start reducing from now on from 30% to 20% to 10%, and I hope it reaches zero soon. So we start messing up with antibiotics starting from the day of birth only. And this is another slide that depicts the significance of antibiotic resistance. So you can see the significance of antibiotic resistance as a contributor to the deaths. So you can see in the first part, self-harm, transport injuries, maternal neonatal disorders, digestive disorders, diabetes and kidney diseases. Those are much smaller compared to the red colored box, which is antimicrobial resistance. We talk a lot about trauma, accidents, diabetes, kidney disorders, chronic kidney disease, dialysis, but hardly ever we discuss about antimicrobial resistance. So that is why it is called a silent pandemic. Nobody pays attention to it, but everybody, in a way or other, is contributory. When I say everybody, it's everybody. You, me, everybody sitting in this room and who's not here in this room. Even people use a lot of antibiotics in livestock. People who take care of, who have farms where they take care of bulls, ox, cows, chicken, all these people, pork, all these industry use a lot of antibiotics, which is also contributing to a lot of antimicrobial resistance. So the burden is quite significant. Does antibiotic prescription only result in short-term complications? No, they do have quite a lot of long-term complications. This was a study published about 2 years back, systematic review and meta-analysis. You'd be surprised to see that there is a group of allergic disorders which commonly occur following antibiotic prescription. You can see atopic dermatitis, allergic sensitization, allergic symptoms, food allergies, allergic conjunctivitis, even inflammatory bowel disease, celiac disease. Many other disorders also seem to present at a higher frequency for patients who are prescribed more antibiotics. I don't know if any of you recognize what this picture depicts. It's not a fish and starfish. It is a depiction of the microbiological flora in our intestines. There are huge number of microbes living in our body. I don't know if you recognize that or not. So the fact is, the human body has more bacterial cells than human cells. Recent research shows that an adult human being contains approximately 30 trillion cells. But however, we are expected to harbor around 38 trillion organisms on our body. So we are actually a walking bundle of microbes. And I'm not sure if the concept of ego or self-identity makes any sense in that perspective. Anyway, that's another topic. So you see that we are made up of 30 trillion cells, whereas around 38 or 40 trillion bacteria are lodged on us and they are living happily. When I say they are living happily, they make us also live happily. Why? Because they are not the harmful pathogens. These are the organisms which are very essential for us to have an appropriate digestive health, to get us free from metabolic disorders, including deranged sugars, deranged blood pressures, and then they protect us from certain types of cancer. They protect us from chronic cardiovascular disorders, mental health. You'll be surprised to know that your gut determines how your brain functions. And they also are implicated in certain immune mediated disorders. In just the previous slide, you noticed that to higher prescription of antibiotics, children or adults do get a lot of allergic disorders. This is because the microbes present in your gut have a role to play in regulating your immune system. So when you mess up with that microbes, your immune system gets disturbed, and hence you land up in immune related disorders. So this is a very interesting study which was published 3 years ago. So you can see the effect of antibiotics that are prescribed on the gut microflora. The x-axis is months. Okay, the y-axis contains all the antibiotics. You can see amoxicillin. It has uh, effect on the person. You can see the red colored bar around, like, say, around 1 month or 2 months. Whereas you see the macrolides, azithro and clarithrol, they seem to have an effect on the gut microbial flora for up to 2 years. That is 24 months. The red colored bar indicates the length to which the antibiotic has effect on the gut microbial flora. The black color indicates how long those patients were followed up. Okay, so you see that it's very alarming. It's very concerning that these antibiotics disturb the microbial flora for such a long time, which is not at all good. So, to sum up the problem statement, antibiotic misuse or abuse is a real problem. It's quite significant. It is multidimensional. It involves you, me, the doctors, the nurses, the pharmacists' children, or whoever takes care of the pharmacists, in the lay public, and the people who take care of farms. It has drastic consequences. It affects our immune system. It affects our gut microbiome. It affects the entire body system as such, and it warrants urgent attention. That's why I'm addressing this directly to the students, because you should carry the right message at the end of this day. Okay, so how do we now we understand the problem? How do we tackle this? So my talk in the next few minutes is going to focus on very simple, practical tips. I'm not going to talk about any international guidelines or policy and bore you. I'm going to take you through certain case scenarios so that you take home some messages which are very vital for you. So when should you use antibiotics? And more importantly, when should you not be using antibiotics? What antibiotic to use in a situation? How much to use? How long to use? How to regulate and monitor your antibiotic use? How do people participate at each level? So these are the questions that I'm going to try and address. I hope you'll gather a few points on all these parameters. Now we'll have some nice time with the people sitting in the 250th row. So scenario one. There is a 2 months old baby girl who was brought to the OPD with a fever of 101 Fahrenheit for 6 hours and poor feeding. The person sitting in the last row. Can you say if you would be interested in starting antibiotics? There is only one last row in this stage. Ah, okay. Yeah, you want to volunteer? I'm happy for that. Thank you very much. You are unable to see from there? I'm visible? Would you like to start antibiotic in this child? No? Because this is a talk about a safe antibiotic use? Yeah. Sometimes that approach doesn't work, because I used to sit in the last bench and I used to have this approach. That's why I designed this question. Actually, this baby requires antibiotics. Sit. Okay, so now we'll move to the girls' last row. A 5-year-old boy brought to the ER at 12 a.m. in the midnight with a history of fever, cough, and cold for 2 days. Elder sibling had a similar illness last week. On examination, temperature was 104, respiratory rate 22. There was running nose, but the chest was clear. Do you like to start antibiotics? Would you like to stand up first? Ah, okay. You are still there. I thought you were asleep. Would you like to start antibiotics? No? If one is yes, another will be no. Good. Yeah. So, see, the reason we want to understand this is how does the first scenario sounds? I wouldn't blame him. He had a logical thinking. This baby had a fever for 6 hours. So he might feel like, why would I start antibiotic? There is no other danger sign that I have mentioned except maybe for poor feeding. Now, when I have a fever, even I have poor feeding. I don't feel like eating. Right? 2 months baby may not be very well. And in the second scenario, although this child is having a much higher fever, 104, but you see the age matters a lot. This child is 5-year old. Okay. So just to put it in a nutshell, the first baby will require antibiotics. Why? Because of the age. Age under 6 months, age under 6 months will be considered very significant because the immune system is not yet developed there. So in age under 6 months old, any fever, we usually take it seriously. Is the answer to this illness antibiotic only? No. We first evaluate such patients, admit, monitor. Antibiotic is one of the ways of managing these children. Can't a 2-month-old baby develop viral fever? Yes, very well can. No doubt. Even 2 months old baby can develop viral infections, but in that baby, I cannot be 100% sure that that is a viral infection. So any baby under 6 months old, I'll be more cautious and more proactive in considering antibiotics, despite the duration of fever, despite the severity of fever, despite the accompanying symptom. The second scenario, this child has crossed 6 months of age, otherwise normal child, presenting to us with high fever, but for a shorter duration, only for 2 days. The mother is presenting to you at 12 a.m. in the midnight, probably because the fever was quite high. The vitals are a little bit deranged, probably because of the fever response. But otherwise, the chest is clear. It doesn't look like a lower respiratory tract infection. So in this child, despite the higher grade of fever, despite the more prolonged fever for 2 days, I wouldn't be keen on starting antibiotics. So how do I decide on starting antibiotic in a child? The first factor is host, age. As I told you, age less than 6 months, we'll be a little bit more proactive in starting antibiotics. Immune status. Say, for example, a child has blood cancer on cancer chemotherapy. I'll be very cautious in that child. If that child presents with one episode of fever, I may probably admit and start that child on antibiotics. Because I don't want to risk. I know this child has a higher risk of having a progressive septicemia. So unless I'm very sure this is not a significant bacterial sepsis, I may take the risk of starting antibiotic in that child. But in a child who is more than 6 months old, who's immunocompetent, which is usually the case scenario, I would be hesitant to start antibiotics. You get the point now? The second point is organism, virus, bacteria, and fungi. You all know that viral infections are usually self-resolving. You don't really need to treat most of the viral infections. Unfortunately, most of us tend to do that. Should not be done. Okay, if there is any definitive evidence of bacterial infection, yes, in that case you might consider antibiotics, but otherwise you can wait. It's not like no decision is taken as a final decision on the day one of fever. Okay, the third factor to consider is severity of the pathology. The same E. coli, Escherichia coli organism that causes diarrhea in a 10-year-old boy, I may or may not consider antibiotics. It's a self-resolving infection. The boy's immune system is capable of taking care of the E. coli in the gut. But if the same E. coli presents sepsis in that same child presents to me with hypotension due to sepsis, then I'm very concerned. In that case, I cannot wait because this is a severe infection. So I'll have to work up the child, lift some samples for blood cultures, and then start antibiotics. Okay, so these are the main factors I would consider: host-related factors, organism-related factors, and the severity of the pathology. Okay, so this is how I decide on whether to start antibiotics. So number is always work to identify the organism before initiating antibiotics. Like I just said about E. coli, a child presents to me with high fever, altered sensorium, and hypotension. If I'm considering sepsis, I should first collect a sample for workup. For example, blood culture. Especially cultures are very very important samples. You should not start antibiotics without taking samples for cultures. It may be throat swab, it may be CSF, it may be blood, it may be urine. Usually, it is necessary for us to collect samples before we administer the first dose of antibiotics. Once you administer the antibiotic, your culture results may be wrongly negative. You may be diverted or you may be distracted by normal results. Okay, so you should always collect culture samples as much as possible before you initiate antibiotics, as I said, and avoid trial of antibiotics. Okay, child has come to me at 12 a.m. in the midnight. Let me start antibiotic. Let me see tomorrow morning the child is well. Let me stop. That is not the right approach. We should not try starting antibiotics with an assumption that it might work. When not to use antibiotics, I would like you all to self-evaluate yourself. When has your father, your mother, your brother, or you yourself have used antibiotics in any of these situations? High grade fever alone. I have seen many people, especially doctors, use a lot of antibiotics when their children have high fever. So it is not warranted. Fever alone, especially in the initial 2 to 3 days of illness, do not warrant antibiotics. Stable child, no danger signs. There are lots of families, especially in India, child will be having a fever of 100, 101, but running around playing at home. But uh, grandmother will catch the baby, grandfather will hold both hands, uncle will hold both legs, the father will open the mouth with both his hands, and then the auntie will be pouring that syrup into the baby. The baby will almost be like gargling the syrup. Should not be done. It is actually an unnecessary medicine, physical and mental trauma on the baby. Parental pressure. It's either parental pressure or grandparental pressure. This is very common in India. When we sit in pediatric outpatient clinics, we have a lot of pressure from the parents. Now, do something. I cannot see my baby tired like this. I have to do something. I have to do to the person who's worrying, not to the baby. Now, I cannot satisfy the caretakers by doing some harm to the baby. That's a wrong practice to do. There is more need for counseling than for antibiotics. Okay, the pressure is quite heavy when it comes to pediatric population. And this is a very common logic all Indians will have, just in case. So what if something happens to the child tomorrow? Something will happen to me also tomorrow. I'm standing here on the stage tomorrow. I may not be standing anywhere in the world. Anything can happen to anybody, right? That is not a good logic to start antibiotics. Don't buy that logic from anyone. Don't even buy it. 10 years from now, you are sitting in an OPD and I walk in. I say, you know what? I taught you pediatrics. You have to prescribe antibiotic to my grandmother. You don't have to listen to me. Anyway, you don't listen to me. That's a different story. Okay, so there is no need to have a fear of deterioration. Okay, just in case. So what antibiotics to use? This is a very big topic. I'm not going to deal with it entirely today because it's out of the scope of discussion for today's 1 hour discussion. So just going to discuss principles. What is the point? What are the points you will consider? First one is diagnosis and the possible organisms involved. Say, for example, a child presents to me at 1.5 years of age with high fever. I check the throat, I check the lymph nodes, I check the respiratory system, and then I put a otoscope in the ear. I diagnose acute otitis media. Here I've made the diagnosis. With an otoscope, I've made the diagnosis acute otitis media. There is a congested tympanic membrane. I know what are the possible organisms involved there, right? It is probably Streptococcus pneumoniae, the Haemophilus influenzae. These are the common organisms there. I will choose an antibiotic which covers those organisms. I would not give that child acyclovir. It doesn't make sense, right? So I choose an antibiotic based on the diagnosis and the possible organisms involved and the severity of the condition. To dictate target attainment. What do you mean by target attainment? See, I told you, acute otitis media may be caused by Haemophilus influenzae, Streptococcus pneumoniae. Does it mean like 100% of acute otitis media are caused by only these two organisms? No. There are multiple other organisms which can cause. But I am not very keen on covering all the rare organisms because it's not a life-threatening illness. On the other hand, if I have a child who is presenting to me with a classical picture of acute meningoencephalitis, I want to cover as many organisms as possible because this child is not going to give me much time. If I delay the diagnosis, if I delay the antibiotic, I may lose the child. That is called target attainment. Based on the severity of condition, we'll have to uh, we'll have to apply our mind and decide whether we need to cover the majority of organisms or the entire gamut of organisms involved in this pathology. Okay. Third one, you all might have read much more in detail in your pharmacology subject is the pharmacokinetics and pharmacodynamics of the drugs. I'm sure all of you know about these basics. You have read it in your pharmacology. The fourth and very important part is local epidemiology. The same organism may not behave the same way in different localities. Right? Say, for example, you have read about leishmaniasis. In India, we have Leishmania donovani mainly. In Central Asia, they have Leishmania infantum. These organisms behave very differently. Their treatment might differ, although the disease is the same. So you need to have an understanding about the local epidemiology. The fifth point is community acquired versus hospital acquired. Say a child comes to me in the middle of the night with acute respiratory infection. I'll consider a community acquired low respiratory tract infection. I'll treat with basic antibiotics which cover the prevalent organism. On the other hand, if I have a newborn baby in my neonatal ICU staying there for 14 days on ventilator, and that baby develops pneumonia, that is hospital acquired pneumonia. So here I'll cover all the organisms that I know are prevalent in my ICU. Usually they are quite resistant. Usually they are a bit more difficult to treat. So you need to understand what kind of infection you're dealing with. Is it from the community or is it from the hospital? And the last and very, very important history is allergy history. When you sit in your clinic, if there is one single point I would want you never to forget at all in your history taking, it is allergy history. It will save two people. One is your patient, the other is yourself and your career. Okay, it's very important. You miss the allergy history, you give a drug, it's the end of two things. One is patient's life and your career. Okay, so it's a disaster. Never miss history of allergies. You might be using amoxicillin for 1,000 patients. The 1,001th patient might be amoxicillin allergic. Mother was in a very anxious mood because the baby had fever and probably a seizure also. So she didn't remember to convey that to you. It's your responsibility to probe that history. You never miss that history. Okay. Scenario three. Finish the 200 crore. Now we'll come to 199. Yeah, you only. Already getting ready, huh? Enthusiast. Okay, 6-year-old boy from a poor family had fever for 5 days. Father approaches a nearby pharmacy. There is a pharmacist child there, 9.5-year-old, giving that amoxicillin clavulanate. So father gives half a tablet twice a day for 2 days. Child improves. Drug stopped. 2 weeks later, child presents to the emergency room with high fever, altered sensorium, and seizures. What's your inference? Your inference is I won't let you happy today during the talk. About this patient, drug resistance. Okay. More than drug resistance, what about the initial management? The child had fever for 5 days. He went nearby and got an antibiotic. Is that right? First of all, you have the power to switch off the lights. Huh? Sit, sit. Is that right? Is it right practice to go to a nearby pharmacy and get an antibiotic? No. It's wrong, first of all. Secondly, what determined the dose of half a tablet twice a day? That is a very common understanding in our country. Even I've seen some doctors also do that. Dosing in children is very easy. 0.5 plus 0.5 is equal to 1. Now, one adult is equal to two kids. That is how it works. Adult takes one tablet, child takes half tablet. A bit smaller child, quarter tablet. I don't know what they will do to a newborn baby. They will crush and have one small city. I don't know. So, see, first of all, the practice of getting antibiotic from pharmacy is wrong. Secondly, self-dosing is very wrong. What has happened as a result of that? The child has started to respond, but there was an inadequate duration of antibiotic therapy. Wrong antibiotic, wrong dose, wrong duration. Everything was wrong. So the infection was partially controlled, giving the clinical appearance that the child has recovered. So the father has stopped the antibiotics. You can't blame him. And then the infection has progressed towards septicemia and a possible meningitis. I don't know. I may be wrong, but this is a very serious scenario. High fever, altered sensorium, and seizures is a very serious scenario, right? So, what do we learn from this? What are the points to consider? One is age and weight of the child. Okay, we mostly calculate antibiotics based on the weight of a particular child in terms of milligrams per kilogram or units per kilogram. So there is a scientific way of calculating. There are studies that come up with these conclusions. We do not come up with it on an approximate basis. There is nothing like approximation. And again, here also you take care of the pharmacokinetics and dynamics. You take care of the organ dysfunctions. If the liver is functioning well, if the kidneys are functioning well, you all know how the drugs are metabolized. Most important two organs involved are the liver and kidneys, and the severity of the condition also. See, the same antibiotic may warrant a different dosing in a severe infection. Say, for example, there is a child A who has respiratory tract infection due to pneumococci. There is a child B who has pneumococcal meningitis. Those may differ between these two children. Why? Because the antibiotic has to cross the blood-brain barrier and reach the brain, right? And it's a more severe condition. So usually the anti-meningitic dose of antibiotic will be a little higher. Not always, but at least for some drugs, it's a little higher. For example, meropenem, it's a little higher. So you have to understand the type of illness you are dealing with, and you also need to take care of the adverse effects and drug interactions. The child might be on 5 other medications already. Child might be receiving an antiepileptic, which might be a cytochrome P450 inducer. You'll have to take all those things into account before you prescribe an antibiotic. Okay, you have learned about xenobiotics in your biochemistry. Remember, there was a subject called biochemistry 200 years ago. We were in first year. Still remember? Eh? Okay, so how long to use an antibiotic? Starting an antibiotic is very easy. Stopping is very difficult. Even the experienced clinicians, they will say, today is Friday evening. Let us see it on Monday. Let the child continue on Saturday and Sunday. Every Saturday and Sunday, antibiotic companies have a nice time because the rest of the clinicians go to rest. Clear understanding of the pathology, organism, and the host are essential to determine the ideal duration of antibiotics. As I said, streptococcal pneumonia, acute otitis media, even 5 days will be enough. Streptococcal pneumonia causing lower respiratory tract infection, you might need it for 10 days. The same organism, severe acute meningoencephalitis or a brain abscess, might require several weeks of antibiotics also. So you have to understand the organism as well as the severity of the illness. So it's essential to eradicate the organism, but at the same time, you should not be unnecessarily prolonging the duration of antibiotics because you have seen in the first few slides what are the adverse effects of prolonged unnecessary antibiotic therapy. So here we come to the concepts of empirical antibiotics and definitive antibiotics. What are empirical antibiotics? You come across a child, you come to a conclusion this child requires antibiotics. You feel like you have to start the child right away on antibiotics. You can't wait until the test results come. So there you start an antibiotic which possibly covers the main organisms which you consider are the possible etiological agents. Okay. As I said already, you should always collect samples like urine culture, blood culture, all those relevant samples, and then start these antibiotics. This is empirical antibiotic. Once you get the results, you modify your antibiotic therapy. You cut down certain antibiotics or you change certain antibiotics, or sometimes you continue the same antibiotic also. That is called definitive antibiotic. So empirical is something you start right away after collecting samples. Definitive is something that the modifications that you make to your antibiotic regimen after you get the results or after you understand the clinical progress in the patient. So we'll again see this scenario. Yeah. There are two people who are already seriously discussing among themselves. Yes, yeah, you only. I'm sure you are thinking about answering this question, no? You have been anticipating this question about half an hour earlier on. So we'll come to you. The last but one row, second person. Yeah, you have to stand. Only then I will know that you are awake. Yeah. So we'll read this question together. 4-year-old girl presents with 2 days of fever and lethargy, followed by drowsiness this morning and an episode of generalized seizure for half an hour. At admission, child had altered sensorium. Temperature was 104, heart rate 150, respiratory rate 52, blood pressure was low, 74 by 52. It was petechial rash all over the tongue. Blood sugar was 36 milligram percent. I hope you can interpret the physical signs. There is fever, heart rate is high, the respiratory rate is high, BP is low, sugars are low. And there is petechial rash all over the trunk. What do you consider in this situation? You will start antibiotics considering septicemia. Good choice. So what infection do you consider here? You consider an ear infection, you consider a urinary tract infection, you consider what else do you consider here? Meningitis? Good. Sit. Good. So here you will consider acute meningitis or meningoencephalitis. What would you do? You will collect samples. As I already told you, initiating antibiotics is very important. Okay, but you should always make sure you collect samples, complete blood count, peripheral smear, C-reactive protein, erythrocyte sedimentation rate, blood culture, serum electrolytes, organ functions, drug types serology, CSF analysis, and contrast enhanced CT of brain. Why am I doing all this? Because I want to understand what the diagnosis is. I want to understand what organism is causing the diagnosis. And I want to make sure the organs are all fine because this, as I said, it is probably a septicemia. The child is in shock. Probably septicemia. So multiple organs might be affected. It could be multi-organ dysfunction also. Right? So I want to know if the organs are doing good so that I can start the appropriate dose of antibiotics. Right? So I'm doing all that workup, and as an emergency management, I'm taking care of airway, breathing, and circulation. Right? Because this child was tachypneic. I don't know if the tachypnea was due to fever or if it is due to an accompanying low respiratory tract infection. I don't know. Circulation wise, this child is in shock. I would want to put in an IV line, give some IV fluids to revive this child, resuscitate this child. It was hypoglycemia, probably secondary to sepsis. I'll treat this child with dextrose. Child was having stiffness epilepticus. If you notice, there was seizures for about half an hour, so I'll give anti-seizure medications. When it comes to antibiotics, I would like to start antibiotics as soon as possible. So you see here, surprisingly, I've listed like 1, 2, 3, 4, 5 antibiotics. So far, I've been telling you be very cautious before you start antibiotics. Don't overuse antibiotics. And here is a scenario where you have a very sick child. The child has sepsis. The child has probably meningitis. The child is in shock. So the child is in a very sick, very moribund state. You cannot waste too much time waiting for your reports. So here, to save this child, you are justified in giving the first dose of antibiotics after collecting the relevant samples. Okay, after doing all this workup. What am I thinking in my mind? It could be bacterial meningitis, it could be viral meningitis, or it could be malaria, related cerebral malaria, or it can be a rickettsial meningoencephalitis. These are the common pathologies according to the epidemiology. If you are talking about 2025 in Hosur, I will probably not consider malaria at the top of my diagnosis. This is the classical approach, but I will always titrate it to my epidemiology. I would probably not give artesunate in this type, but it's okay. For the sake of learning, we'll continue that. So after about 4 hours, I get some results. My CCT shows meningeal enhancement because I've given contrast, meninges enhanced. That indicates I'm dealing with a meningitic child. And then the total counts are 36,000 with predominant neutrophils. CRP is very high, elevated. The smear shows no malarial parasites or microfilaria. CSF shows prophylactic leukocytosis once again. And scrub typhus serology is negative. So what have I done here? I've confirmed my diagnosis to be meningitis. Since there is hyperleukocytosis and elevated CRP and 250 cells, predominantly neutrophils, I'm probably looking at a bacterial meningitis. It's not viral, probably. I've ruled out malaria. I've ruled out scrub typhus. So what I'm doing after 4 hours, I'm shifting from empirical antibiotic to more definitive, rationalized antibiotic therapy. What I'm doing here, I'm stopping artesunate, I'm stopping acyclovir, I'm stopping doxycycline. I hope you all know, right? And artesunate is for malaria, acyclovir is for viral meningitis, and doxycycline is for rickettsial meningoencephalitis. So I've stopped all the three. I'm continuing ceftriaxone and vancomycin. Again, practically, I may or may not use vancomycin. That is probably to cover the penicillin-resistant pneumococci, which is increasingly being recognized in India, but it's okay for the sake of discussion. So 4 hours later, I was able to remove 3 antibiotics here. It's a very important decision. You cannot say I've done everything. Now I'm feeling hungry. I'm feeling sleepy. I'll go to bed. I'll view this child after 9 hours of sleep and 1 hour of WhatsApp and 1 hour of reels. After review this, I'll review this child after 12 hours. No, it cannot happen like that. At 4 hours, you have to review your decision. By doing this, you have given only one dose of artesunate, one dose of doxycycline, one dose of acyclovir. You have minimized the unnecessary antibiotic exposure in this child. 48 hours later, CS of culture showed Neisseria meningitis. So now you know the diagnosis. This is meningococcal meningitis with septicemia. That petechial rash all over the trunk is characteristic of meningococcemia. Okay. So now I know it is penicillin sensitive. I don't need vancomycin anymore. So I'm cutting down that also, and I'm continuing with ceftriaxone. So you see, you started with 5 antibiotics. In 48 hours, you've come down to only one antibiotic. So this is how you should de-escalate antibiotic therapy. It's extremely important to start life-saving antibiotics, but it is equally important also to de-escalate antibiotic so that the child is not unnecessarily exposed to prolonged antibiotic therapy. This is how the WHO has beautifully classified the approach to antibiotics. This is just like your traffic signal. The access group of antibiotics are the ones which have less potential to develop resistance against the organisms. They are the ones which you should be using more frequently. Like for example, penicillins, macrolides. The yellow one is you should be watchful. You should see if there are alternatives. If not, okay, you can use the yellow colored group of antibiotics. The last one are reserved. So you reserve them for multi-drug resistant organisms. Okay. Say for example, when I was of your age as a student, my pulmonologists, my professors commonly used to use fluoroquinolones for chest infections, like levofloxacin, moxifloxacin. Those were very commonly used uh, 15, 20 years ago for respiratory infections. Nowadays, these are very important drugs for treating multi-drug resistant tuberculosis. So nowadays, pulmonologists do not always straight away go with these medications so that they don't inadvertently expose the tubercle bacilli to these precious antibiotics. Linezolid, for example, it was a very commonly used anti-staphylococcal agent in my period. Even now we use it, but not as a first choice because linezolid is again an integral component of multi-drug resistant tuberculosis. So I'll have to take all those things into consideration. If I have a better option, I will not use this reserve group of drugs. Okay, so you need to clearly apply this concept in your mind. Whenever you choose an antibiotic, you need to understand if it falls in the green, yellow, or red category. Other factors to consider are accessibility. This is very important. Your mobile generation, whenever a patient comes to you, if you don't know anything, perfectly fine to look online, perfectly fine to refer your books, but be pragmatic and realistic. Sometimes you put something in your internet, it comes up with a first preferred antibiotic. Probably the drug is not even available in India. It's available only in the United States. So you shouldn't be prescribing that with practical application of knowledge. Cost, very important, especially when you are practicing in India. It is very essential because the third point is closely related to the first point. You might say, tablet this 3 times a day for 3 weeks. Is the patient affordable for 3 weeks of that antibiotics? It might cost 3,000, 4,000, which might be the entire month's salary for the daily wage laborer. You never know. You have to understand the socio-economic background as well. Very, very, very important is clear documentation and counseling. You know, you all have heard the 15,955 jokes about doctors' handwriting. It is true. We are one of the groups of people who have the worst handwriting in the world, and nobody has anything wrong in accusing us of that. It should never happen. Prescription should always be in capital letters. Anybody who knows alphabets should be able to read your prescription. If not, indicates that you are not confident while you are prescribing. That's as much as it is. There is nothing more to it, nothing less to it. So you should prescribe in capital letters. You should document it clearly and counsel the patients very precisely. Okay, 199 throw in the boys. Somebody is meditating. Yeah. You can awake from yourself, come into the real world and stand up. Yeah, yeah, you only. Yeah, you only, Pa. Last but one row, the boy. You want some other description. You know, the one with the enlightenment. Ah, yeah, you. So, see, you have a 1-year-old boy with 1 day of fever. Okay, very dangerous family. Huh? Let me tell you. Father is a plastic surgeon. Mother is a radiologist. I hope neither of them are available here. Just a hypothetical situation. Okay, pressure from grandparents of not doing enough. You know, baby has fever in the morning, given paracetamol, laying around. Evening again, baby has fever. That is a medical emergency anywhere in India. Second episode of fever is a medical emergency. Except for Narendra Modi, they will contact everybody. Okay, so this baby was started on amoxicillin clavulanate because of grandparents' pressure on day one. Okay, this is a 1-year-old baby, not less than 6 months. Mind it. Okay, day three, fever persisting. So they consulted a pediatrician. Okay, so child was evaluated. Complete blood count showed 20,000. Uh, little bit of neutrophilic dominance. CRP normal value is less than 6. So this was a little bit elevated, 26. Blood and urine cultures were sent. 2 days later, no growth at all. What would you do? He's saying, I am not that pediatrician, sir. You will get this situation 1 year or 2 years later. People will call you for this. What would you do? Okay, I'll tell you what happened. This baby was continued on amoxicillin clavulanate for 5 days and then stopped because by the fifth day, the culture reports came negative. Fever also resolved. So everything was stopped. Everybody happy. Grandparents very happy. Baby has always been happy. Parents also now happy. Pediatrician got the consultation fees. So he was also happy. So baby was well for 2 weeks. Okay. After 2 weeks, baby presented with a fever of 105 Fahrenheit, lethargy and poor feeding, admitted and evaluated. Initially, total leukocyte count was 20,000. Now it is 36,000 with 84%. CRP shot up further. Initially, it was 26. Now it is 292. Urine culture showed Klebsiella pneumoniae. ESBL is extended spectrum beta lactamase. Okay, meaning that it is a very resistant organism. It produces beta lactamase, meaning it destroys beta lactam antibiotics. Okay, and ultrasound abdomen showed pyonephrosis. I hope you understand what this is. That is pus in the kidneys. Why did this child land up in this situation? Organism is resistant. Yeah. If the organism is resistant, nothing would have changed, right? Why would this child land up in this situation 2 weeks later? See, you notice the problem here. Sit, sit. Notice the problem. This is the problem here. This child was started on amoxicillin clavulanate on day one. See, you have to remember in your in vitro tests, when organism is resistant to a particular antibiotic, it may not be entirely resistant to that antibiotic in vivo. See, if I have an organism which is resistant to amoxicillin, I take amoxicillin, it might be partially effective. That is what probably happened in this child. That resulted in urine culture being normal. So it kind of diverted everybody, the parents, grandparents, even the pediatrician. It diverted everybody from the existence of a possible urinary tract infection. After that, the resistant organism started growing in numbers. Infection gradually progressed and resulted in a grave complication, which is pyonephrosis. So what should have been done ideally? This should have been prevented. Let the child have fever. Give paracetamol. Wait until day two. Wait until day three. Then evaluate the baby. If you had done urine routine and urine culture before you started amoxicillin clavulanate, probably you would have grown the Klebsiella initially. That would have been a lower urinary tract infection, which you could have easily treated with oral cotrimoxazole or any other drug that was sensitive. Now, what you did is you partially treated for 5 days with a poorly sensitive antibiotic. You partially suppressed the infection. It flared up without being recognized clinically. 1-year-old child, do you think the baby will be capable of complaining of dysuria? No. It got aggravated subclinically. It resulted in a grave complication of pyonephrosis. So, what happened to this child? The surgeon had to insert a pigtail catheter to drain the pus from pyonephrosis. Baby required higher antibiotics. Meropenem and amikacin for 14 days, ICU stay for 5 days, recovered, discharged. You think that will be the happy end to the story? It's not always like Tamil films. Huh? Sometimes the end is like Bala film. Follow up after 3 months, you do a dimethylsuccinic acid DMSA scan to find out if there are any scars in the kidney. Left kidney shows a scar. See, remember that growing kidneys in children are very precious. Any insult to those kidneys, even with an infection, can result in scarring. That scar persists for life and it can result in long term consequences like hypertension. This baby developed hypertension at 1.5 years of age, continuing on antihypertensives. Very likely will require antihypertensive for the rest of her life. Unfortunately, this baby also has the risk of progressing into chronic kidney disease later on. All due to what? Yielding to the unnecessary pressure and starting antibiotic on day one. Simple mistake. And not evaluating appropriately. Okay, this is real. This is not a cooked up story. These things happen on a day-to-day basis, many times not recognized, not documented. Okay, so never use antibiotics indiscriminately. The lessons you learn here is do not start empirical antibiotics without proper evaluation. If these parents would have sent urine routine and culture before they started any antibiotics, probably they may have had a better approach. Do not try to treat the symptoms with antibiotics. Okay, fever is not a sign of surprise on disease. Okay, I'm sure some of you as adults, you also, when you have a little bit of tummy ache, you have some one or two loose stools. How many of you have the habit of taking cefixime with metronidazole? I'm sure many adults do that. Don't do that. Diarrhea is not a sign of metronidazole deficiency. Cough is not a sign of cefixime deficiency. Don't do that. Mostly, you won't require an antibiotic. Trust your body's immune system. So, thereby we come to the concept of antibiotic stewardship in pediatrics. This is a beautiful document released by American Academy of Pediatrics in 2021, reaffirmed this month in 2025. What is stewardship? It's practice dedicated to prescribing antibiotics only when necessary, and when antibiotics are necessary, promote the use of appropriate agent, appropriate dose, appropriate duration, and route of therapy. Route of therapy. I have not emphasized that until now. Very important. I cannot treat infective endocarditis with oral antibiotic. I do not treat meningitis with oral antibiotic. I can treat acute otitis media with oral antibiotic. I can treat tuberculosis with oral antibiotic. You have to understand that the route of antibiotic therapy is also equally important. Okay. So the 4 Ds of stewardship is correct drug, correct dose, correct duration. Very important to de-escalate on time also. I've told you about de-escalation already. The diagnostic stewardship is make use of diagnostic techniques like cultures, rapid diagnostic tests, C-reactive protein or procalcitonin. And there should be a hospital antibiotic policy. Okay? Like we have 10 pediatricians in my team. We cannot go around using antibiotics as per our fancy. I cannot say, in my experience personally, I've used this antibiotic, it works well. No, it doesn't work like that. We need to have a policy so that all of us practice the same thing. And it is very important that pediatricians, especially, uh, serve as the advocates for appropriate antibiotic use. And as pediatricians, I not only restrict it to that group, but in general, as doctors, we should all be wary of that. And practical do's and don'ts for daily practice and use or not, abstaining from the use of antibiotics should be re-emphasized to the parents also. So coming back to my first slide, I hope all of you have the answers to these questions. My child has a high grade fever. What antibiotic should I give him? No antibiotics to be given. My baby coughs incessantly. Wait. If at all possible, auscultate. If there is a wheeze, see if bronchodilators might help. Or worst case instance, can try cough syrup. No, not much role for amoxiclav or azithromycin for incessant cough. Child is too sensitive for blood tests. Everybody in the world is sensitive. Try to convince the child, get the appropriate investigations. Leaving abroad, happy journey. No antibiotics. Daughter has exam tomorrow. I'm a doctor, not a magician. Thank you very much. That's the answer. Okay. So answer to all these questions is I'm sorry, best wishes. When you keep doing that in your practice, your bank balance will be like this. But that's okay. Not a problem. Right? Money doesn't gain happiness. It's more important to do the right thing. Right? All of you agree with that? Yeah. So if there is one message that you will take today, stop indiscriminate use of antibiotics. Stop it for yourself first. When you develop fever and your father or mother develops fever on day one, do not self-medicate. Approach a doctor, have an open conversation, see if they recognize any danger signs. They say that no, in your background we have to start antibiotics, go ahead with it. No problem. That's usually an exception. That's not the norm. Okay, so I want you to understand the concepts of antimicrobial resistance and the importance of microbiome in your body. Respect the microbes in your body. Don't disregard them just because they are not visible. Okay. So the messages I would want you all to carry today is fever alone doesn't warrant antibiotics in a stable individual. Do not self-medicate yourself. Do not fall prey to the societal pressure or just-in-case culture. Always question the need for antibiotics. Remember to de-escalate the antibiotics. Be aware of antimicrobial resistance and the microbiome. Okay. So that brings me to the end of my talk. Any questions? I'm happy to take it.
Thank you, sir. That was a very thought-provoking, engaging, and entertaining session. So I would request our Dr. Raghu sir, our HOD, to give away the momentum to Dr. Arvind.
Thought provoking, I'm not sure. Entertaining, I'm pretty sure.
Okay, now moving on to our next speaker is Dr. Siddhalingaya, currently working as Senior General Manager of Clinical Development for Vaccines at Biological E Limited. He has played a key role in introducing the Verocell JE vaccine to India's national immunization schedule. A prolific speaker, he has delivered over 100 senior lectures across India, Nepal, and Vietnam, and is widely published, including a paper in Lancet Regional on COVID-19 boosters. He's an alumnus of Advanced Vaccinology course at CMC Vellore and co-authored a book, MedPG Threshold Aims Record. So today we'll be speaking on the topic vaccine vigilance, a subject of immense relevance in the current times. Please join me in extending a warm welcome to Dr. Siddharangaya.
Hey, good afternoon. First of all, thank you, Dr. Arvind sir. It was really a thought-provoking session. In fact, of course, entertaining to all of them. And I would say, if you want to, probably go further in terms of antibiotic stewardship or preventing the antibiotic resistance, probably start using vaccines. So that is the one message probably can bring down the antibiotic, the unnecessary use of antibiotics, and also probably promote like the health and well-being of humans. So, of course, I know that this is a lunch break time. Allow me almost at least 30 minutes. I will try to cover up some of the important things about what is vaccines pharmacovigilance and how it is done in India and what is the importance of vaccine pharmacovigilance. So briefly, I'll touch upon what is the importance of vaccines and vaccinations, basics of vaccines and why vaccine pharmacovigilance, and some of the key definitions we use in adverse events related to the vaccines, and briefly understanding the India's pharmacovigilance system for vaccines and what are the tools we use, both paper-wise and the digital-wise, and who are the key actors and responsibilities they take while doing pharmacovigilance for vaccines, and summary. Of course, like say you know that vaccines. So if I look into the importance of vaccines, so we look into in terms of how cost effective they are in especially the advancing the children's health. If you look at the US, UNICEF says that in fact probably they are the most cost effective means of advancing child health. And also WHO says that probably it is the most successful and the most cost-effective health intervention probably we have. And in terms of like say the investment and the earning, if we look at, so probably it is one of the high return on investment for low mid income countries. If I spend $1, probably it will give me almost or it will save close to $44. And another important thing we should remember, we should be proud of that India is the largest vaccine maker in the world, supplier. In fact, almost 60% of the global vaccines are made from one country, probably the one state which probably gives much, probably the Hyderabad followed by Pune. Basics, of course, like say, I don't go into details, but vaccines, like say, to understand the adverse events related to the vaccines, probably the basics will tell you something. Like vaccines means, like say, we take something from the microorganism which is made as harmless or less harmful and we inject or give, and the body should identify this as a threat and should respond by generating the antibodies and also the cells. So these antibodies and cells in the form of memory, so they attack and protect you the near future whenever there is a real threat comes across. So the goal of vaccination is to prevent the infection or the disease. If that is not possible, at least it should prevent the severe outcomes like deaths and hospitalization. In terms of the components, of course, the vaccines has multiple components. All vaccines may not contain all, but many of them. But the active ingredient is the most important thing that is called the antigen. And we also add some of the components to increase the immunogenicity of the vaccine called adjuvant. And during the manufacturing process, they may need antibiotics. So there may be some traces of antibiotics in the vaccines and stabilizers, especially when the vaccine is in the powder form, preservative, especially when the vaccine is the multi-dose vials, and some of the other, like say, which are used to inactivate the virus or something like that, like formaldehyde. So adverse events, whenever it happens, it can be directly related to the active ingredient, or it may not be related to the active ingredient, it can be related to the other components of the vaccine. And types of the vaccines, of course, there are multiple types, but live attenuated, inactivated, and like say the subunit are the most commonly used, like say, types. And now recently, due to the COVID, we also have two important vaccines called nucleic vaccine, that is DNA vaccine from the India and RNA vaccine from the US and also from the India. Then viral vector vaccines like Covishield. Of course, when we look at the like say you look at like say the reactions which happens to the vaccines, of course, there are common reactions which generally mild and go up easily, and there are uncommon or very rare reactions which might, like say, affect the trust in the vaccines. Coming to the most commonly used vaccines or the recommended vaccines, of course, the government of India takes the lead in the vaccination. Almost 90% of the vaccination happens through the government of India. There are 12 vaccine preventable diseases against which vaccines are available in the government of India, and IAP for the private, like say, populations. Of course, there are multiple other vaccines apart from the all the vaccines which are given in the government of India. And like look at some of the case scenarios. So, of course, I will not ask like Dr. Arvind sir because I don't know. But like look at one of the thing like say, infant, probably 6 month old infant was given a oral polio vaccine, and within few days, the baby developed acid paralysis, which was asymmetric, and the CS episode, like say, rise, like say, the lymphocytes, and no, like say, sensory loss means, and no household people are involved, are ill. Another case, a 2-month-old received, like say, a vaccine as administered subcutaneously in the until it was die at day 7, the baby presents with painful swelling, and the baby was febrile and feeding well. And third case scenario, a 12-year-old girl faints 5 minutes after HPV vaccine shot during a school like session, and of course the baby like she recovered. So if you look at the three case scenarios, so the reactions due to the vaccination, so it can be always attributed to the vaccines. It can be attributed to the like say vaccination, the vaccine errors, and also it can be attributed to the vaccine anxiety. The first one is actually the one which is attributed to the vaccine. It was vaccine causing the problem. The second one, it was the injection which was causing the problem. Ideally, it was supposed to be given intramuscular. Somebody gave subcutaneous that resulted in the abscess. Then the third one is an anxiety related disorder, which is very common, especially in the teenagers, which has nothing to do with the vaccine, it's more to do with the injection fear. But when we look at, so we always look at all this and later we evaluate and come to the conclusion. The vaccine programs, like say, as I said, like say, of course, vaccines are very effective, but at the same time, they suffer from their own success. Like example, like say, if you look at, like say, probably in India, of course, vaccine uptake is much better now compared to the US and the Europe. Why? Because like say in India, the disease, there's so much of disease, and the vaccine knows that the people know that the vaccines are working, people are taking the vaccines. But in the US and the Europe, where the disease has come down significantly, now the people are questioning when there is no disease, why should I take a vaccine? At the same time, when a small event happens, it may be a rare event happens, so we look at that up looking at the how beneficial the vaccine. So that is the reason why probably like say the developed world are suffering from their own success which they had probably the 20 years back. Coming to the pharmacovigilance, of course, the definitions, it is the activities linked to the detection, assessment, understanding, and prevention of adverse events. It also includes the vaccine-related problems. What is the difference with the vaccine pharmacovigilance? So vaccine pharmacovigilance only adds one more thing. It's also communication. Of course, even the vaccine pharmacovigilance also deals with the communication, but vaccines communication is of one of the most important thing because that is the one which gives you the success at the vaccination program. Coming to the points which are to be considered for pharmacovigilance in the vaccines. So first thing you should remember that vaccines are generally given to the healthy people. Means of course we give some of the vaccines to the other like say maybe a cancer patients or some other like say immunocompromised patient, but generally the vaccines are to be the healthy people means so like so that first don't do means don't do harm first. So means like so when you're giving something to the healthy people, always we have very low threshold for the adverse events. Means like say you have very low tolerance because I'm healthy and you're giving something to me and which is causing a problem that is more dangerous than like not giving anything. So when you give something to healthy, make sure that you have a very good, let's say, vaccine. In terms of course, rare adverse events happens. Of course, we'll evaluate those, but it's one of the things in the pharmacovigilance why it is important because it is given to the healthy people and it has very low tolerance for the any adverse or the risk. And second thing is age of vaccination may coincide with the some of the developmental abnormalities, like especially like say maybe some like say like neurological issues which happen. So you give a vaccine and suddenly after some days neurological abnormality starts, then people starts linking the vaccine to the development. That's what is happening, like say especially autism linking with some of the vaccination practices. Then coming to the like say generally the rare adverse events requires very large number of like say the population need to be vaccinated. I mean it needs robust surveillance to come across or to report and assess the rare adverse events. And another thing for the public immunization programs like India is cluster of cases. Probably you will see some of the newspapers that okay, pentavalent vaccines administered, 3 children died. So that is a cluster of patients, and that brings down the vaccination acceptance by the public significantly. That affects the vaccination significantly. So that is a public concern, and we need to investigate that rapidly with utmost importance and also communicate accordingly. And programmatic errors mimic product issues. Like say some of the examples you like say probably you come across, like already I told one, like say the injection of vaccines to the subcutaneous instead of intramuscular causing like say the abscess which is linked to the vaccine, which is actually the programmatic error. And similarly, like, there are multiple cases have happened. Like say one of the example was babies were administered measles vaccine, and within few hours, the babies developed paralysis. So later, when they analyzed, they came across that the fluid which was storing the vaccines also stored the muscle relaxants. So MR vaccine, instead of using the MR diluent, they use the muscle relaxant and administered. So it results so we need to look at the programmatic errors because they also mimic the vaccine adverse events. And paramount is sustained confidence, sustained coverage, and the disease control. So if you don't take this like seriously, it will affect the like say confidence of the people in the vaccines, and which will affect the coverage and the disease control. Okay, sorry. Another thing, like say vaccines in some of the vaccines in some of the countries are mandated. That's also another important thing. When you mandate something, so make sure that the vaccine is of utmost safety. Otherwise, like it will affect the acceptance. And another thing about the vaccine pharmacovigilance is low visibility of the benefit. Like say example, like say I take or I give a vaccine for HPV, which is probably going to occur at the age of maybe 50 years or the 60 years. Very long duration, which probably I don't like say probably look at that, and also probably we don't know unless we get the disease. So we never like say understand the importance of the vaccines because like the vaccines prevents or not prevents you don't unless you get the infection. Next, serious adverse events which needs to be like say investigated thoroughly and communicated. Non-serious, they may be non-serious, but definitely they will affect the public confidence. So I was a public health officer in, like say, Chikmagalur district, in one of the Karnataka district. Like say, first I went, like say, with the nurses to give a vaccine, which was only dedicated to that part, which was called KFT, Castor Forest Disease vaccines. And we are calling the like people, nobody is ready to take. We are asking what is the problem. Everyone is saying like, like itching after taking the vaccine, the swelling. They may be non-serious, but they are affecting the like, say, acceptance of the confidence of the public. Then another thing, challenge is like say generally in the pharma we do de-challenge means we take out the drug if we suspect or if you want to prove again we give the this one. But Such things are not done in the vaccines, which are generally not feasible or not ethical. So assessing the causality is a little bit difficult in vaccines compared to the pharma products. Then co-administration. Generally, during the initial program, even in trade practice, generally we give generally two vaccines or three vaccines. Which, like say, if some reaction happens, then of course we may suspect, but generally it is very difficult to assess the causality. Like I give, like say, excellent vaccine. I also give the like PCV vaccines. If a fever occurs or pain occurs, generally I don't like say look at like which has caused this one, because both can cause the fever, both can cause the like say injection site reactions. Then risk communications. So that is also one of the like yes, of course. Generally, like say as I said, like means like say like recently, like so probably you heard like say in Karnataka. So some of the politicians talked about the COVID vaccines and causing the heart attacks in young populations. Of course, multiple, like say, people rushed into it, doctors rushed into the, even AIMS doctors came in, and the like say, Jayadeva doctor in Bangalore came in to explain that no, no, it has not caused. But that has not Ali means like say, brought up the confidence of the public to take up the vaccine. There is strong evidence to say that no, the vaccine has not caused the problem, but something has happened that has caused the let's say some news. So that is very difficult to bring down. And evolving platforms now, you know that now recently the suddenly new platforms came, like say RNA vaccines came, viral vector vaccines came. They came suddenly, and we don't know the long-term safety and also the safety initially. So like yeah, means so strengthening the safety, especially for new platform vaccines, also very important in vaccine pharmacovigilance. So why, like say, we do vaccine pharmacovigilance? You know that, like say, during the clinical trials, we test a limited number of subjects. So many rare adverse events, very rare adverse events, probably may not be picked up during the initial clinical trials. So vaccine pharmacovigilance definitely brought up that. Then during the clinical trials, we generally exclude some of the risk groups which might, like say, the vaccine, pregnant mothers or immunocompromised, people with comorbidities. The actual scenario, we may give the vaccine to this population. So again, the pharmacovigilance is important to detect the safety in those people. And then, like say, why are we doing the pharmacovigilance? So one is we need to ensure that the vaccine is safe, and we need to build the confidence in the public, and we need to capture the rare and the serious adverse events which are undetectable during the initial clinical trials, and we need to recognize not only that and like say treat and prevent the like say the reactions, and also any prevent emission errors and take the corrective actions. And if anything happens, so investigate the coincidental events causing, suppose like say I give a typhoid vaccine, next month the baby develop a dengue. So it is a coincidence, but like say you never know why it has happened. So it is important that we need to like say evaluate properly so that we the false claim of the typhoid vaccines causing the dengue. Then document and convey these, especially to the community where especially there is a cluster, and also estimate the rate. Some of the key definitions we use during the vaccine pharmacovigilance. The most important one is AEFI is called adverse event following immunization. So it is similar to what the adverse event we call it as any untoward happened following vaccination, which may or may not be related to the vaccine, but it happened during the that time, so it is suspected. Then something known as adverse event of special interest. In this example, now we know that probably there are very rare reactions which would happen due to the mRNA vaccine like myocarditis or viral vector vaccines like TTS. So these are called adverse events of special interest means we know something that needs to be monitored when somebody takes a vaccine. Then something called serious adverse event or serious adverse event following immunization, similar to what we define the serious adverse events like death, life-threatening, hospitalization, disability, congenital anomaly, or any medically important. Another thing probably we don't use in probably in the pharma, but we use in the vaccines called medically attended adverse event. Means adverse event which resulted in the person going to the healthcare person to take or to seek the guidance. So adverse event happened. So I took my child to the doctor. Doctor prescribed something that became a medically attended adverse event. So how do we classify the adverse event after vaccination? So we classify generally as minor, severe, and serious. The minors are usually like say, course means they occur within few hours and they generally go off without causing any problems. Severe, they generally go severe means disabling but rarely life threatening. Severe also includes the serious, but not all serious means severe or serious. So serious, as we discussed, death, patient, hospitalization, persistent disability, then AF clusters, concerns, all those. So like as I said, like say severe also includes the serious, but not all severe infections are serious. Example like say a febrile seizure, it can be a severe, but may not be a serious. High grade fever, then injection site, abscess probably, and OPD basis may not be a serious, but it's a severe reactions. WHO, they have a something called causality assessment for the any vaccines adverse events. So one is called vaccine related means this is the reaction which is attributed to the vaccine per se. Then vaccine quality defect related. So like say example like say something like say the vial broke down, something happened, contamination happened. So these are all quality related. Then immunization error, I told injection site related something. Then I also told about the mixing some adjuvant with the vaccine. Those are all immunization error reactions. Immunization triggered stress, like especially I told about the like this injection fear resulting in the lack of like a scope, especially during the adolescent vaccination, especially mass vaccination. It can be due to like MR vaccines happened multiple times. Probably the going forward, it's also expected to happen. The HPV vaccine is going to start soon. Then coincidental, I told like say I gave some vaccination, something happened like I gave typhoid vaccine, malaria happened, or dengue vaccine, so dengue happened. Those are all coincidental. All these generally are done at the year level, means district, state, and the national level, not at the base level, like say the causality assessment. So error related, you can see that, like say non-sterile injection, like say like my syringe or the injection site used, or precaution error I told, then injection site, like say incorrect, then like say incorrect storage of the vaccine. And contraindication, like say again, I want to emphasize Dr. Arvind sir told, means you should remember the, or you should not forget the allergy, especially in the vaccine, you should not forget the allergy because the vaccines are known to cause allergic reactions because they are injections, means known to cause allergic reactions, and that is going to say have a serious like, consequences for you and the patient. And anxiety related, especially as I said, it occurs during the mass vaccination campaigns. So it is not related to the vaccine components, but it is important because that is going to have significant impact on the public acceptance of the vaccines. And how do we like say frequency wise say the vaccine is like say common, uncommon, rare. So if you see the like say more than 1:1, it is called very common, common, like say more than 1 in 100 to less than 1 in 10, or you can see the percentage wise. So rare, like say 0.01% to less than 0.1%, whereas very rare is less than 0.01%. So these are some of the like the reactions, frequency. You can see, of course, they are very rare reactions, but let's say whatever we talk about the vaccine related probably are the let's say means we talk about mostly these which are affecting the public acceptance of the vaccines. But if you look at the means the let's say frequency, they occurs in few thousand to let's say few lakh doses, means one case per few lakh doses. Even like if I look into the COVID, you see that like say two important like say thing which has attributed to the COVID vaccines were one is something known as ATS, is thrombotic thrombocytopenia, and second one is myocarditis. All they occurred like say one in few lakh cases, but still that brought down the public confidence of the vaccines. So goal is to early detect and take the appropriate measures and also to respond to the public accordingly. And like of course going broadly, like say vaccination pharmacovigilance mainly goes with the public because as I said, 90% of the vaccination happens in the government. So most of the vaccination pharmacovigilance system is built across the like say government system, starting with the primary health care, whether Anganwadi workers or ANM or the medical officers, the district, state, and the state level, sorry, miss the central level. So who are the, like say, key people here? Of course, we all healthcare professionals and the other government bodies which are involved in the monitoring the adverse event following vaccinations. And also the Central Drug Laboratory that is in the Himachal called Kasauli, which tests the vaccines before releasing into the market and also whenever a complaint comes, the quality test. And what are the key roles? Of course, we all, our role is to recognize, stabilize, document, report, and counsel the patients. Then the district level, they investigate the cases and they do the necessary causality assessment, whether it's related to the vaccine, related to the other things which I told, other four categories. Then the actual, the causality generally happened at the national level. And also they review anything, new thing comes, which is probably suspected, but needs to be evaluated called signal. Then the Pharmacovigilance Program of India, of course, they all collect the case report, then they analyze the PSR and also the CDSC who takes the regulatory actions. And as I said, laboratory, like say Kasoli, it is the one which tests the vaccine. And who can inform? So we all can inform the adverse event following vaccination, starting from the base level, that whether it's rural, starting with the ASHA worker and all the like say in the medical setting, whether it's nursing staff or the hospital staff. And we have a tools now to report this one. Of course, not all can report so you know that COVID came up during the COVID vaccines, but now the same one is now used for the reporting the adverse events called SafeVac. So it like say you can see the SafeVac site, and generally the ones which have the access to the COVID means who has the COVID password. So they are the ones who can report the adverse events to the COVID app. And surveillance, of course, like say, as I said, happens at the base level, that is detection. then reporting, then the state level generates the causality assessment, signal detection, and the central level again causality assessment, signal detection, and also let's say giving the feedback to the companies and as well as the regulators. And this is the case report form which we generally use to fill any adverse event following vaccine. Of course, you can use the regular one which is used for the drugs also, but this is more advanced in terms of because it has much more data captured. So for the causality assessment, so this is also available which can be utilized. Of course, generally officers at the government officers they use this, but in your system, you can also use the regular AD or reporting form also. And anything happens, you can there is a like say the safe pack, like say like email ID is also there. You can contact that the report. And causality, they said like say they are like say related to the vaccine, are quality related, error related, anxiety related. Of course, if nothing is related, then we determine that indeterminate. Then also we may say coincidental. So another tool, like say we have another like say, of course, not everyone like say you can access and you can like say learn the how to do the causality assessment from the e-tool developed by the WHO. There are dummy cases given, so you can also go through that. And there you can also enter the real cases. It will direct you how to do the causality assessment. So this is much more complex, but this is the signal management. Like something comes from the field, so like say also like say you can see the literature, SMPs, PSUR, all those things. Then the licensure data also. All these things like say what's the signal management, which will as a signal review panel, and that makes the recommendations, and that goes to the different committees like NTAGI, SEDESCO, and again that is communicated to the, at the either the manufacturers or the healthcare professionals. What is the responsibility of the manufacturers? Like us, let's say what we do generally, like we have a dedicated pharmacovigilance system, and we like apart from the clinical trial, we collect the individual case safety reports. Then we do the like literature search and also literature surveillance. Literature surveillance means like say we not only collect the initial reports, we also like say look at the like media reports, social media reports, paper reports, or all those things they are collected, and also we look at the government websites because something known as line listing means government whenever a vaccine like adverse events come, they list them, and that comes to us, and again we evaluate them. And another thing is periodic safety update reports. Like unlike pharma, generally first 4 years new drugs because in India very rarely we have new drugs in pharma, but vaccines are called new drug for the whole life. Means you should have the PSR entire life cycle of the vaccine. Means first let's say 2 years we submit every 6 months, then after that every year we PSR. Unlike pharma, first 4 years we submit the PSR. After that, no, that for the new drugs, not for the generics. But in the vaccine, there is nothing called generic, all are called new drugs for the entire life period. Then we also like say attend the like say the meetings with the regulators and also coordinate for the testing and stability of the vaccines. And like we do the individual case in terms of the passive surveillance that is collecting the doctors, like say the like, complaint forms. Then also like say we encourage the SCPs like we dedicate some of the centers we try to establish where we encourage the doctors to report the adverse events and as I said, periodic safety reports throughout the life cycle. And also whenever required, of course, we generally do the post-marketing trial for every vaccine. And whenever something new thing comes, if additional safety assessment has to be done, we may undertake another phase 4 trial. Private practitioners, of course, as you are considered, like say, either area form or the case report form is showed, and generally the contact person, of course, you can contact the market authorization holders to report, or you can also be in touch with the medical officer at the government side or the district immunization officer, which are the more direct connection to the vaccination adverse events of the pharmacovigilance, and report all serious severe adverse events immediately within 24 hours with the report. And also, like, there are like, serious reactions, tries to have the discharge summary report, all the investigations, and that needs to be submitted, and also tries to keep the, like say, vaccine at the vial probably, if it is used and like say still there, like say tries to keep that, because that may be required for the testing purpose. Another important thing, especially you all consider, so whenever you are sharing something with the media, please have some do's and don'ts, because that is the one which is now which is very effective and can make or break the public immunization program. So whenever you say something, so it is best to refer that like you, whether the district or the state spokesperson or the within the hospitals, probably the hospital spokesperson to interact with the media people and avoid sharing the identities of the patients, and also maintain the confidentiality of the any patient we having the adverse events. Then documents, suppose there are something rumors, please bring those rumors to the emission program people, and also escalate them to the DFI committee so that they can take the actions to, like say, either evaluate them and also respond to those rumors. Like if, as I told, happened with the, like say, minister is talking about the adverse event of the heart attack following the COVID vaccine. Those are called rumors. Of course, like cluster. So whenever cluster means any cases happen within a period of time. So like say it can be related to the emission error, can be related to the quality, all those things. And a methodology to evaluate. And finally, like what about the patients? Can the patient report the adverse events? Of course, now like we have aware your safety. Even before that also, like say, there are reports of the form where the consumers can directly report the adverse events. Even the reports are there in probably all the important local languages. So I'm talking about here Telugu, like Tamil, Kannada, any like say local languages. There's a phone number given, so you can, this public can contact these reporting. There's another thing is vaccine safety net. So this is very important because, like say, for during the COVID time, so anybody started talking about the vaccines, let's say rumor reactions or the safety related, but which one to trust? So WHO has brought up something called as vaccine safety net. These are nothing but these are WHO accredited websites that provide the reliable evidence-based vaccine safety information. Who runs this? WHO, and there are multiple like say websites plus 50 countries, 41 languages, and within India, which are the ones. So probably sir should be proud again. So Indian Academy of Pediatrics, ACVIP is one of the website comes under the vaccine safety net. This is the most reliable source to look at the vaccine safety in India. Again, the Health India project, then medical dialogues. Probably you have heard of medical dialogue, a private like online with a digital one which use the most of the related formal related the vaccines. These are the trustworthy sites to look at the vaccine safety. So to summarize, vaccine PV carries significant importance because has direct impact on the public immunization program. So our role first is to stabilize the patient, report fast, and investigate thoroughly. And of course, there are multiple difficulties to learn and also to report. And whenever, because it is mostly related to the government program, so tries to engage with the immunization program officer or the district immunization program or the A committee, like the rumors and have clear compassionate communication with confidence with the vaccinee who has adverse event and also the media or the public who questions you regarding the vaccine safety. And please educate the public which are the most reliable source to check the vaccine safety, that is the BSN. So with this, so thank you very much for giving this opportunity. Any questions, I would be happy to take.
Thank you, sir. That was an informative and interesting session, elaborating the difference between PV and vaccine vigilance and giving us an industrial perspective of the topic. Now I welcome Dr. Sujata ma'am to give the memento to Dr. Siddhalingaya. Next, we'll be having a very interesting clinically oriented session by Dr. Deepak Anand after we break for the lunch. Okay. Mhm. So we'll have a half an hour break for lunch. So please be back soon for first session by 2.
Students will get the attendance once you will come for the afternoon session. If you are not coming, you will not get OD. Okay. So try to assemble as soon as possible. You have 4 sessions in the afternoon.
Hello.
Welcome back, everyone. So, we'll be starting our sessions. Before that, we'd like to give the memento for Dr. Raghu sir by Dr. Aravind. Sir, now Dr. Sujata by Dr. Aravind. Thank you, sir. Okay, so next we have a very interesting clinically oriented session by Dr. Deepika Anand. So, introducing him, the Associate Professor of Internal Medicine and Deputy Medical Superintendent at St. Peter's Medical College, an MRCP physician, intensivist, and diabetologist. Dr. Deepak is the organizer of Convergence Series and Lupus Day Series. He has been a keynote speaker for the M2C Foundation course and organizer of more than 10 series. He serves as medical director of Ananthashram Hospital and founder of Janarakshan Hospital. His research interests include diabetes with critical care technology, AI in medical education, and obstructive sleep apnea. So today we'll be speaking on to patients. Please welcome Dr. Deepak.
Good afternoon. First of all, I would like to thank Department of Pharmacology for giving me this wonderful opportunity to discuss some of my insights or my perspective about pharmacovigilance. Big thanks to all the students who returned back to the CME after the lunch break. Okay. Don't worry, this will not be like a very formal session. It will be more like a storytelling because we are going to discuss some clinical vignettes or our experiences or our encounters with regards to pharmacovigilance, which we had in our clinical practice. Can we maintain silence, please? Or should we wait for everybody to settle down? Okay. While the tech team is trying to sort out what is wrong, I would like to add two important points to the topics which was covered during the morning session. One was the antibiotic use and misuse by community pharmacists as well as doctors in general. As a diabetologist, where I am more concerned about this, the recent concept is antibiotic misuse in children directly contributes to adolescent obesity as well as younger onset of diabetes or higher prevalence of diabetes in Indian population. Though as we speak, evidence is pouring in. We know for sure, or for that matter, we know beyond doubt it is proven that the gut microbiome are to some extent responsible for maintaining appetite, maintaining satiety, maintaining normal body weight or BMI, as well as prevention of obesity, metabolic syndrome, and diabetes. So, higher the incidence of childhood antibiotic use, greater the chances of adolescent obesity, and greater the chances of diabetes in young onset type 2 diabetes in later life. That is one thing. Second thing, just to add to the point, add to the talk that Sir gave, I think if you ask me, which is the milestone for humanity in 21st century, I'll tell that is the development of COVID vaccine. Because normally for a medicine to come to market, it takes around 3 decades. So we are able to develop a COVID vaccine, test it, and deliver it safe relatively. It's a highly effective, highly efficient, and a safe vaccine within a span of just 2 years. Normally, the timeline takes 3 decades, and we were able to do it when the organism was creating chaos, confusion, and pandemonium all around the world. Okay, so I think if you ask me, regardless of whatever criticisms that may be leveled against the COVID vaccine by the politicians or the community at large, I think it is one of the best, pinnacle of human success in the 21st century. Can we go to our topic? Yes, I think the slide change is working. So like it said, mine is going to be like a storytelling. So before we go to our story, can you just check that word flow? So can you tell me, in medicine, we don't take things for granted. Whenever there is a truth or whenever there is a hypothesis, we try to test it. We test it by means of different types of epidemiological studies. Which type of epidemiological study you think is the best and the most robust type of epidemiological study? Can you click that orange? Can someone answer that question? There are different types of studies, quad study, prospective study. Somebody can answer? They'll be able to see which is the best type of epidemiological study. I think 77 people are still active. You have lost at least one correct response, one correct answer from any participant. It can be from faculty also. Because this question is relevant to today's topic, which is pharmacovigilance. Okay, when we want to bring a drug to the market, what type of study do we conduct on patients? Should I come down and fight with madam? Because I heard from madam that you all passed pharmacology just now. RCT, very good. Full form for RCT, randomized control. See, the highest level of evidence, the evidence they say systematic reviews and the meta-analysis, etc., etc. But most robust, if you want to answer a question beyond doubt, you want to be very sure, you will do something called as a randomized control trial. Next slide. But what is the problem with RCT? Can someone tell me? It means they are logged into the browser. So classpoint marketing, the morning classpoint.app filtering a browser login பண்ணீங்கல அந்த பேஜுக்கு போங்க. You open either Chrome or your Safari browser. You go to that page. You type classpoint.app. You enter the class code, which is 49710. Enter your name. So you'll be able to see the slide. Start the activity. What is the problem with RCT? Can someone tell? See, nothing can be too good to be true. There will be some pitfalls. So, what is the pitfall of RCT? That is the concept of today's topic. Practical difficulty, very good. RCTs are little cumbersome. They need meticulous design. They need to be conducted properly. Cost, they are very costly. Difficulty, yes. Expensive. That's why we have our industry partners who do the sponsoring for us. Time consuming, very good. So blinding we can do. Blinding we can do. Time consuming, again, it depends on the type of medicine or the type of effect you want to see. But what is the actual problem with RCT? The RCT is done in a RCT tends to overassume or oversimplify things. It is done in an ideal population. So it does not reflect the real world conditions. So if you want to bring a drug to the market, you do different types of RCTs, phase 1, phase 2, phase 3 trials. But the problem is you do in idealized patients, patients who do not have comorbidities, patients are otherwise perfectly doing well. You just are studying only the effect that the drug is going to bring about. So that is the problem with RCT. So though you do a lot of RCTs and you prove that the drug is both safe as well as efficacious, when the drug performs in the real world, sometimes the drug might, drug or for that matter even vaccine might behave little differently. With the real world experiences, real world comorbidities or real world variations come into play, that the drug is going to perform little differently. That's why in the levels of trials you have something called as post-marketing surveillance or phase 4 trials. And this post-marketing surveillance is very important because many times two things can happen. Side effects which did not occur during the trial might crop up in the real world thing. Sometimes the side effects which were, either masked or they were like neglected as very trivial might become the major factor. See, sir spoke about the thalidomide disaster. See, I'm a diabetologist. As far as diabetes is concerned, there's something called the rosiglitazone debacle. So rosiglitazone was a PPAR gamma agonist which was brought to the market. It was a wonderful drug. But when it was launched into the market, they found out that people taking rosiglitazone were having higher incidence of myocardial infarction, which is actually counterproductive because the very reason why you are controlling blood sugar or the reason why you are controlling diabetes is to prevent heart attack, neuropathy, and nephropathy. And this medicine is actually doing the opposite thing, and oxycodone had to be withdrawn from the market. Later on, they found out that it did happen even during the RCTs, but it was due to some reason or either out of deliberation, it was neglected as not statistically significant. So after this rosiglitazone debacle, it was made mandatory that any anti-diabetic drug that comes into the market should undergo something called a CVOT, cardiovascular outcome trial. So that is something, and I'm not going to go into the definition. Don't worry, because it has already been discussed in detail. All the three scenarios that I'm going to discuss today are real. There are no hypothetical if or whatever. I'm just presenting as they happen. See, the first case is we have an 80-year-old gentleman who is a diabetic hypertensive and he obviously is also having the coronary artery disease. He has had undergone some intervention in the US a long time ago and he is on secondary prevention now. Now, the thing is, we didn't see him for diabetes per se or CAD per se. Actually, he did come to get the green flag to start a small dose of systemic steroids. It was little, little surprising for us. Why did he need to start corticosteroids? Uh, he was under a lot of medication. If you can see, he was on cardiac medication. 1 and 2 are cardiac medication. 3 and 4 are allergy medication. 5 BP, 6 happens to be diabetes. 8 and 9 being supplements, and the 7 being something for his prostate. And he is on 2 allergy medications, and he is also on a nasal spray. So his main problem happens to be is allergic rhinitis. He is having a persistent vasomotor symptoms, running nose, nasal stuffiness, etc., etc., etc. So he tried topical therapy, he tried antihistamine. Now, and he has seen multiple ENT surgeons. Some of them wanted to start him on steroids, and they can start here because his diabetes was very well under control. And he was advised steroids, but he still wanted to check with me if it is okay to start steroids. Uh, and can you tell me whether we can give the green signal to start steroids or should we need to introspect further? A is give steroids. B is wait. Very good. The word steroid rings alarm bells. Nobody wants to be for steroid. Okay, very good. But as many times we cannot refuse. From dermatologists, from ophthalmologists, from pulmonologists, we often get this request, and we behave like நாங்க இருக்கோம், நீங்க கவலைப்படாதீங்க, நாங்க இருக்கோம், we control the sugar, how much ever steroid you want you give. Because during COVID we have seen, even we have personally given up to 2 grams of methylprednisolone for the benefit of the patient. We have revived patients with like insanely high doses of steroids. Okay, very good. Nobody wants to start steroids so the activity. So a little bit more about this patient. This patient is not a normal patient. See, he was a US, he still is a US citizen. Repatriated to India, but he still retains his US citizenship. He himself has bronchitis like history. Okay. So it is more likely that he can have allergic rhinitis. Both his elder brother and younger sister also have allergic rhinitis, bronchial asthma, urticaria, all types of atopy. And he's not seeking my support, he's just seeking my opinion. And for him, rhinitis is the number one cause of concern now. And the more problematic thing is, see, all three in this generation are my patients, but the next generation, most of them are actually either doctors or nurses or some form of healthcare administrator in the US. Almost everybody in the next generation. So we already had trouble managing the patients in the past. They said, sir, after 79 years, there is no role of statins. Statins, can you stop? Why are we still giving him metformin? Already his renal function has deteriorated to 60 ml per minute. Why are we still giving metformin? All sorts of things. And I wanted to put the point that our healthcare system is better than what they have in US. And I used this as an opportunity because I knew why he was having rhinitis. Again, I think we already discussed about this. Anybody wants to tell what is happening with the patient? Why is he having rhinitis? See, anybody can have allergy, everybody can have atopy, but to start having an atopy or allergy at 80 years of age is not usual. If he had to develop it, he should have developed it at a younger age. He should have had some symptom, and he is not that ignorant to ignore trivial symptoms. Not anti- So he is not that ignorant guy. So he should have. The second thing is we have given sufficient amount of topical steroids, topical decongestants, and antihistaminic, and montelukast. But still, he is not. It's not coming under control. Immunosuppressant. Actually, immunosuppressant should help. No? What he is having is some form of heightened allergy. Okay. Have you forgotten today's topic or the point of today's theme is pharmacovigilance? So it has to be something to do with the drug he is taking. Can someone point out which drug can it be? Okay. Activity closed. Okay, go to the next slide. He was taking, as far as diabetes is concerned, he is taking only one medication, which is Nanomet, sitagliptin with metformin. He is more we probed into the history, we found out that he was on a different group of medication. He was on sulfonylurea with metformin, and this Janomet had recently come into the market as a super drug. And we don't deny the fact that they are a super drug because even as a diabetologist, if you ask me, it is the most favorite group of medication among anti-diabetics, but it is different. That is DPP-4 inhibitors because fire and forget type of drugs. They are very durable. They don't have or absolutely no risk of hypoglycemia, and they are weight neutral. And combined with metformin, they work wonders. So he is on that medication. And even if you take any dossier about DP4 inhibitors, this minor fact about DP4 inhibitors is ignored in all publications. These DP4 inhibitors have a tendency to cause something called as staphylococcus. We don't know why they mentioned this term as staphylococcus. You take any dossier or product monograph, they will not mention it as a rhinitis. They will mention as a staphylococcus. So I challenged him that if he changes his medicine, he will get better, but he did not agree. But what happened was otherwise. He stopped that medication. Within, I think, 1 to 1.5 months, he became completely clear. He came off antihistamine, and he came off all the nasal sprays, everything. He did completely fine for the next 8 to 9 years through which he lived. And he had lot of referrals from his relatives because we were able to clinch one point which lot of ENT surgeons and even next generation doctors in his own family could not detect. So that's about that case. So what is very important is we should be absolutely clear and coherent about all the medications that we use in practice, and we need to keep abreast of all the information because the opposite of this thing also happens, which I have not put in the slide. See, I was giving the same group of medication to a patient. The patient came back to me with fluid. Obviously, we don't treat pruritus. We refer the patient to dermatologist. After seeing two, three dermatologists, the patient got frustrated. When the patient visited a dermatologist in Chennai, the dermatologist picked up a rare side effect of the medication, which was coming up in the literature. And after stopping the medication, the patient also became better. So it is very important that we stay abreast about the medications that we use, especially in an era where we have a lot of litigations and medical legal things going on. It's always better to stay clear of any trouble whenever it comes to medications for long-term use. Coming to my own experience with pharmacovigilance, this happened around the time of COVID. I could not recollect whether it was 2020 or 2021. That was the time. See, whenever proton pump intervened, we had only one thing in the IV formulation for pantoprazole. People were coming with rabiprazole, and a new IV esomeprazole was launched. So there was a pressure, market pressure to the gastroenterologist. See, one is market pressure. The second thing is patient pressure. Because for us, we have different types of antidiabetics to play around. But for gastroenterologists, for to suppress the acid, IV formulation only pantocid is there. The moment they prescribe pantocid, sir, I already taken pantocid. I've already taken omeprazole, patient filter. So there was pressure for the gastroenterologist. So our gastroenterologist started using it. And see, whenever patients come, they do have some problems with the glycemic control. So I was called, but we were able to pick up some unusual patterns in glycemic control. People who were started on that IV esomeprazole, they are getting abnormally the sugars were coming under control even without our intervention, or our medicines were working out of the normal ranges that we expect them to work. And we were able to fix that all three were on IV esomeprazole. No harm was caused to any patient, but still we tried to contact the manufacturer. See, we are a small hospital, we don't have this PVPA and all. But when we contacted the manufacturer, they responded promptly. They removed that batch of medicine and they refused to tell us what was actually wrong. They told that they will supply a different batch of medicine, but I refused. I told my gastroenterologist, no, let them sort out what it is, then we will find out. Because just I think I've discussed this enough in my classes. Hypoglycemia is very unusual. You have a biochemistry book called U. Satyanarayana, where circus animals will be kept. There'll be one elephant which is insulin that is trying to bring the sugar down. There'll be some eight animals trying to pull it upward. So it is naturally physiologic for sugar to go up, not down. So if the sugar is going down, it could be some insult to gluconeogenic process, which can happen from either liver or kidney. So what happened was we did not use the medication. To our surprise, so the manufacturer did not tell what the problem was. The medicine was recalled completely, and the medicine was reintroduced only 2 years later into the market. We never bothered to look into what happened, and I also, in retrospect, I felt whether I had overreacted to the issue, whether I was correct or not. Then I found this publication. See, ideally, you are not supposed to publish pharmacovigilance related things or the new adverse drug reaction of a medication in the journal unless the journal belongs to you. This belongs to a corporate hospital. They can publish whatever they want. So in their newsletter, they had published a similar thing. This happened at the same timeline when we reported the hypoglycemia. And there were 12 incidents of clinically documented life-threatening hypoglycemia. Fortunately, all the patients were revived because they are all inpatients. And we do till now we do not know what was the culprit or what was the you know additive that caused the hypoglycemia. But now whatever esomeprazole we are getting nowadays are safe. We, I mean, I have not personally started using it. I've seen my surgical gastro started using it again, and the patients are doing perfectly fine. So that's the importance of pharmacovigilance for you. Even you can practice it even a remote place or a small place. unless you are vigilant, sometimes you can miss things. And if you are vigilant, you can actually save a lot of lives, or you can save a pharmaceutical company from going into bankruptcy. You have saved two parties because if, imagine some patient dying of hypoglycemia later turning out to be because of the medication, they can directly sue the pharmaceutical company and make it bankrupt. And for the pharmaceutical company, again, it's going to become a loss. So I mentioned it as a case secret two, but it is three. Uh, I had a 30-year-old gentleman, 36-year-old gentleman, recently diagnosed hypertensive. The workup for secondary hypertension was complete. They had done most of the things except the endocrine part, but most of them were negative. His BP was under control, and he told he had a gas problem. He had a lot of joint pains. Later, it was found out to be hyperuricemia. And his complaint was the moment he walked in, he told, "Sir, I want to spend some time with you. I need to talk. Please spare some time." See, time is a luxury that we don't have in private practice because in private practice, time is money, and in private practice, we are valued less than mutton biryani. Okay, a mutton biryani costs more than our consultation fees, and the more swiftly you do away with the patient, the more patients you can see, the more you earn. But patients don't value that, so they will try to extract maximum time out of you. So I was thinking that this is some kind of patient. See, he is taking antihypertensive. He has ruled out all the secondary causes of hypertension, but he wants time. Can someone tell me what he is trying to tell me? He is on four group of antihypertensives. One being diuretic, so he falls into the category of refractory hypertension. And there's something called uphold. Uphold is tadalafil. Tadalafil 1 SOS. Can someone tell me what is tadalafil? PDE5 inhibitor. What is it used for? Erectile dysfunction. Very good. So that's what he wants to convey to me. So he's having erectile dysfunction. He has told to his previous physician, but he dismissed that because he's having a vascular risk factor. It is common, but it is easy to say that it is common to have erectile dysfunction with hypertension, diabetes, and all. But for a patient who's just 36 years, it's going to be devastating. And see, I did not waste a single second. I told you I can understand what is your problem. I just tweak your medication, you will become fine. Can someone tell me which is the culprit here? From the student side, you can answer in the word so that is it the thyroid diuretic or is it the ARB or is it the metoprolol? So tell me, Satan, hydrochlorothiazide, one calcium channel blocker, one beta blocker. Thiazide, beta blocker, very good. The answer is actually beta blockers. Okay, and I did not, I was not surprised at why you had to be given that high dose of metoprolol. If you see the prescription again, he was given 100 mg of metoprolol. In such high doses, we tend to go only to prevent deterioration of heart failure or to prevent exertional angina or hypertension control per se, especially in young individuals. We don't use beta blockers, but the person who prescribed the beta blocker was also my friend. I can empathize with him because the way this patient behaves, he behaves like a type A personality. He's having heightened emotions, so he wanted to have maximum sympathetic love for this patient. So he probably used metoprolol. In his place, I would have used something like a super sedative beta blocker, like bisoprolol or nebivolol. And once we took off the metoprolol, the patient was actually happy. So the case in point is if the patient comes with a complaint, especially pertaining to lifestyle disorders, long-standing ailments, it is always better to introspect and review the medication once and find out if the symptoms are being caused by the medication because it will work wonders for the patient. For you, it's just a stroke of a pen, but for the patient, it can mean an ocean's difference. Okay? And coming to the last case, actually this case we have actually presented in professional forum as a case report because this was the first time it actually happened. So again, we have a very elderly gentleman. So he suddenly gained weight. Like he gained around 12 kgs over 3 weeks. And the weight gain was not because of fat, it was actually because of fluid. He was getting abdomen distension, fetal edema, and facial puffiness. And on top of this, he also developed progressive shortness of breath. He did have a fever 1 week back, but it was treated. Like the fever got settled within a day or two. He had low urine output, and he started having cough on lying down. Can someone tell the differences? Type the differences, please. So facial puffiness, leg swelling, abdomen distension, breathing difficulty. So nobody is there. Breathing difficulty is the symptom. Actually, if we click the breathing difficulty, we will be able to see who answers. So when you answer with caution, we'll be able to review it in my house and get back to you during the class. Answer responsibly. Okay, anyway, the activity is over. See, it is very straightforward. The patient is having volume overload. Okay, patient is probably having pulmonary venous congestion. That's why on lying down he is having cough. He is having breathing difficulty. Coming to the remaining rest of the history, he is hypertensive, hypothyroid, dyslipidemia. But surprisingly, with all these things, he is not a diabetic yet. He is having NAFLD, and he has the gastritis and habitual constipation. The caveat here is he is a case of nasal bronchitis. So when he had breathing difficulty, his wife, who is a retired matron from railways, she thought that the breathing difficulty was because of bronchitis. She kept giving him only bronchodilators like Nervlin tablet, inhaled salbutamol, terbutaline, etc., etc. But he kept on gaining weight. And what was very unusual for this patient was walker. The walker is recently, I mean, it's there in the market for almost a year or two. Recently, what happened was the manufacturers gave it to two or more pharmaceutical companies who started marketing it very aggressively. And this was started exactly the time when he started gaining weight. And this is for constipation, this is for gastritis, the other things are for thyroid, BP, and lipids. And this coincided with the starting in medicine. But if you see in a strict sense, this medicine is used for fatty liver disease. It reduces insulin resistance, and in all the trials done so far, it has either not caused any weight gain or it has caused modest weight loss because of reduction in insulin resistance. But the problem was this medicine was tried 2 times a day only for 2 weeks, not for more than that. The usual dose of that medication is 4 mg once a day. The person who prescribed it, being a surgeon, probably did not know whether it was OD, BD, or AAD. During my internship, our seniors used to tell if you don't know how to prescribe, whether it is BD, AAD, or OD, you give it as BD. So he probably assumed it that way and he started giving it as BD, and that turned out to be disastrous for this patient because uh, these are the other small details of the patient. Again, he is a non-smoker and everything else was fine. Only thing is he had treatment volume. What will be the treatment? The treatment is obviously going to be diuretic. And see, we were able to prove that breathing difficulty was not because of bronchitis. We did ECG. ECG was normal, but lung ultrasound was showing signs of pulmonary venous congestion, pulmonary edema. Uh, and the filling pressures were high, obviously, and everything else checked out. Only thing was there was a temporal correlation with the weight gain, volume retention, and the medication. So we could not think further. We thought the medication we diagnosed it well. There were other, distracting things. Also, there was some acute kidney injury. TSH was slightly high. Both can contribute to volume retention, but both return to normal as the patient convalesced. And even TSH, we did not do TSH again because because the FT3, FT4 were normal. And the NT-proBNP was why this case being important is this was in the hospital is it was uneventful. We had him in our hospital only for 3 days. He never required ICU admission, and within 3 days he lost all the weight that he gained in the last 3 weeks. So with this priority. So the patient had volume overload state. So the volume overload state could have been because of acute kidney injury secondary to the NSAID. But the NSAID was taken only once. It was unlikely to have caused acute kidney injury, and the hypothyroidism, though the TSH was high, it later turned out to be euthyroid state. FT3, FT4 were normal, and he was otherwise clinically euthyroid. He didn't have to increase his thyroid dosage. So, whom should we blame? Should we blame the kidney, the heart, or the thyroid? The thyroid checked out fine. The heart, again, once we stopped the diuretics, he never required diuretics again. And his filling pressures returned to normal. His lungs became dry on ultrasound. And the kidneys, even the creatinine became normal after we discharged him. I think after a week or so, the creatinine also became normal. So we were left only with the new buzz in the market, which is the Voxar, which is Saroglitazar. The uniqueness of Saroglitazar is a uniquely Indian product. This molecule was developed, developed in India, and it is being manufactured and marketed by an Indian company. And in all the trials, it has worked wonders for NAFLD. It has caused modest weight loss. It has been weight control. But this is the only occasion. But the problem is the safety margin was checked only for 2 weeks. 8 mg per day was checked only for 2 weeks. This patient took longer than 2 weeks. But even otherwise, the moment he started taking 4 mg 2 times, he started developing weight gain immediately, not after 2 weeks. So we thought we'll just report it in a professional forum because it can, with such a narrow index of therapeutic index, it is risky, especially all these patients who have NAFLD are going to have other cardiovascular risk markers. So it is little difficult. And why this gain factor is because it is closely related to another medication, pioglitazone. I think we spoke about rosiglitazone. Convener of rosiglitazone is pioglitazone. Pioglitazone exists in market. It is a wonderful anti-diabetic drug, but the only problem with pioglitazone is this weight gain and volume retention. And this is like a cousin. Saroglitazone is like a cousin. PPR gamma agonist is your pioglitazone. This is like a dual agonist, gamma plus alpha agonist. Sorry, it's a alpha agonist, but still we couldn't find out why it retained volume because it never did in clinical trials. So that's it for today's talk. I would like one before I conclude today's talk. I would like to quote my professor's words. He is Professor K.V. Trivangaram. He is known as the professor of professors. Like he was a professor in MMC. He is the professor of all the existing professors in Chennai. He used to tell us, be the last person to use a new drug because he was very, I mean, at for his age, he used to think that even though the drug enters market, there is still a lot of things need to be learned about the drug once it reaches the post-marketing surveillance phase. But I would not like to conclude my talk on a negative note, so I would like to tell safety first, science always. Thank you.
Thank you, sir. That was a very enlightening and powerful session. So now we would kindly like to invite Dr. Raghu sir to give me the mic to the topic. So next session we have Dr. Santosh. Associate Professor and Department of Pharmacology at Sri Madhusudan Sai Institute of Medical Sciences and Research. He earned his MBBS from MVJ Medical College, Bangalore, and MD from Government Medical College, Mysore. Dr. Santosh serves as Member Secretary of Antibiotic Stewardship Committee and is a member of Prescription Audit, Pharmacotherapeutics, and Medical Education Committees. With over 9 years of teaching experience, he is the Deputy Coordinator of AMC Pharmacovigilance at SMSIMSR and has published extensively on ADR monitoring and pharmacovigilance. Today, he'll be talking on the topic eco-pharmacovigilance.
Good afternoon, everybody. So I'm very thankful for inviting me to this college for Dr. Raghu. He has been an old friend of mine, and my old HOD, Dr. Sujata ma'am, is also here. I'm very happy to be here, actually. Thank you. So, can you guess word culture? Has anyone seen it in your lifetime? Has anyone seen live, not on TV? Live, have you seen? You can lift your hands. Let me see. Yeah. So nowadays it is very rare to see these vultures. But if you ask your parents, maybe grandparents, they would have seen it. Now, why do you think there was a sudden decline in the vulture population? This is an Indian vulture. So now what happened? This vulture, which was a stable species for some 80 to 160 million, in our late 1980s and 90s, we introduced a drug called diclofenac for use in cattle. Okay. So when we did that, what happened? The cattle which consumed this diclofenac, when they were dead, these vultures, as you know, they feed on the carcasses of these vultures. So these vultures developed kidney failure, multi-system organ failure, and there was a drastic decline in the vulture population, which you can see in the graph. And now the vultures are bred in captivity. Now they are again being returned. Now their population is bred in captivity, and now they are. Okay. So yes. Now you can see this lot of articles. Okay, you can see that diclofenac introduced and how the vultures died. Okay. So now you can see that a drug which was intended for use in cattle. Okay, that entered into the vulture and they started dying. So in today's topic, we'll see how this drug enter into the environment, pollute the environment, and how it will affect the aquatic, animal, and even human. Okay? Today's topic called ecopharmacovigilance. Okay? So, how we'll go through the contents is that first we'll see the definition, then we'll see the seriousness of issue. Okay, about the ecopharmacovigilance, we'll see the sources of pharmaceuticals, their route of entry into environment, the consequences of their exposure, actions to minimize the entry and effect of drugs into environment, some legislative measures, and so what is this ecopharmacovigilance? From morning, you must be continuously hearing pharmacovigilance, pharmacovigilance. Now, this is ecopharmacovigilance. Okay, the same definition applies, but the change is that there is, it can be defined as science and activities concerning detection, assessment, understanding, and prevention of adverse effect or other problems related to the presence of pharmaceuticals in the environment. Okay, this is the change. The pharmaceuticals in the environment which affect human and other animal species. This was coined by this scientist called Gianfula Velo. This is the person. Okay. Now we'll say this. And we know that uh, nowadays or in the past century, there is increased consumption of drugs. Why there is increased consumption of drugs? Primarily, there is rapid increase in world's population, In 1800, there were only 1 billion people in the world. By around 1900 to 1930, there were around 2 billion people. Now, where do we stand? We stand here. 8. Okay. Now we are 8 billion people in 2020. And we know that gradually the population goes on in. As the population goes on increasing, the consumption of drugs also goes on increasing. And to add to that, there is increase in disease burden. Okay, especially nowadays we have this uh, non-communicable disease, diabetes, blood pressure, obesity. All these are on the rise. Okay, then there is increased life expectancy. Okay, so people go on using drugs for a lot of time, and fast continuous development of pharmaceutical industries. So all this combined is leading to increased consumption of drugs. Okay? And especially in India, what is the status in India? We know that India, the Indian pharmaceutical sector is currently the third largest in terms of volume. It is 10th largest in terms of value and contributes to 1.72% to the GDP. Okay, it is the largest producer of generic drugs worldwide. Okay, and it is the source of 60,000 generic brands across 60 therapeutic categories and manufactures more than 50 different APIs. So if you see this graph, India is doing more of exporting of drugs and less of importing of drugs. So on one side, there is the most populous country in the world is India. So there is a huge population which is consuming lot of drugs, and on other side, we are also producing lot of drugs. So India has to balance this burden. Okay, we'll see how the increased consumption, increased production, how it affects the environment. We'll see in a few slides. Play the video. Now just look at this video. Play the video. Just look at Yes. So this is one of the videos which shows that there is high level of antibiotics in the environment. Okay. Now I'll show you some studies which also shows that there are high levels of antibiotics can be detected in the environment. I've observed this study done by Carlos Rodriguez and co. It shows that 27 pharmaceuticals were investigated in the aquatic surroundings, meaning the river and the water bodies. And it was found that 19 drugs or other metabolites were identified in the aquatic bodies of Mallorca, Spain. That is, out of 27 drugs, we were able to detect almost 19 drugs in the aquatic environment in Spain. Now, in this one done in Canada, shows that 35 pharmaceuticals were found in 79 of the 95 participating First Nations, okay, at the 285 water sites. Okay, so 35 pharmaceuticals were found in various places, and this is one more landmark study which was done. across 1,052 locations in 104 countries and analyzed for 61 APIs. APIs is active pharmaceutical ingredients. So you can see that this study was conducted worldwide, and what it was found that you can observe, okay, 101 to 200 is the higher level, 31 to 100 that is also high level. India is also in that area. Okay, this is country wise where we are finding highest level of active pharmaceutical ingredients in the surroundings, in the environment, in the water bodies. And you can see, according to the therapeutic groups, if you see, antibiotics are the ones which are highly found in Asia, okay, in the environment, the surrounding water bodies. And if you see drug wise, means drug specific site wise, it is Pakistan in Lahore, where there was highest level of APIs were found, and next in Bolivia, and next in Ethiopia, closely followed by India also in Delhi. Okay. And if you see drug wise, carbamazepine, metformin, and caffeine, this was the highest drugs which were found in the environment. Now, what about India? Is there any studies which were done in India? In India also, there was a study done in Patancheru of Andhra Pradesh, where 150 times the highest level that found in USA. Okay, so the normal levels, no, the environment, and compared to that, it was 150 times higher. Okay, yes. And in this study done in River Yamuna, it was found that antibiotic concentration in the river water contained high levels of ofloxacin, amoxicillin, and erythromycin. This is about River Yamuna. And what about our Kaveri River? In Kaveri River also, it was found that 3,330 nanograms per liter of carbamazepine was detected in the Kaveri, which is 273 times higher than that of the Tamarabarani River. So now you can see that there are high levels of the drugs which are found in the environment. Now we'll just see how these drugs enter into the environment. Okay, what are the sources? So if you observe the sources, the major sources, pharmaceutical excreta, pharmaceutical industries, which lead to lot of wastewater disposal that contaminates the surrounding environment. Okay, that is one thing. Next, consumers. As consumers, the patients, we lead to lot of excretion. The drugs we consume gets metabolized, excreted, but still they are active. They are not totally inactive. They are active and they go into the wastewater system and contaminate the environment. Okay. One more source is hospitals. Hospitals giving out lot of waste, and agriculture and aquaculture. A lot of pesticides, the drugs, the veterinary, all that lead to extra waste into the environment. So if you just follow from pharmaceutical production, the pharmaceutical production, wastewater treatment plants are actually supposed to recycle, remove everything. But many are not so effective, so they directly live into the fresh water. Next, veterinary pharmaceuticals, okay, from aquaculture, livestock, animals, they also leave a lot of waste. This side, human pharmaceuticals from hospitals, they go into the water. Households, they also go into the water. So ultimately, everything is going into your underground, groundwater. So what are the consequences? Now you can tell me, let it go. What is the problem for us? So now we'll see what are the consequences of so much high level of drugs in the environment. Exposure to pharmaceutical pollutants in the environment for a long duration can result in subtle but cumulative effect in both animals and plants that can lead to chronic toxicity. What are the different problems that can occur? Disruption of microbial ecosystems, cytotoxicity, endocrine disturbances, mutagenicity, teratogenicity, development of antimicrobial resistance, and other effects. This I told you in a blanket statement. Let me quote some examples. Now, if you see this one, the environmental estrogens, the estrogens which were found in the environment, the 17 alpha ethinyl estradiols, widely used in industries and medicines, has caused, this is a documented study, has caused feminization of male fishes. male fishes have become feminine. Okay. Now the breeding is interfered and female like male fishes are born, okay, in lot of places where is well detected, and the population of these fishes are coming down. The contraceptive tablets used in water has caused sterility in female frogs. Now that frog doesn't know whether it's a male or female. Okay. So their populations are also coming down. Next, the fluoxetine, which is an SSRI, is affecting the frogs, shrimps, fishes, their reproduction, growth, and even behavior of them is being altered. All these are documented study. And how can we forget the Minamata disease, which were seen in Japan? Okay, so lot of problems has had occurred. Okay, now coming to humans. In humans, there is no direct studies which has been proven yet. But till now, no confirmational evidence is present to establish a causal connection to a particular problem. However, many lab studies are being conducted, which is being extrapolated, okay, to human health impacts. So, as a result, nowadays we are seeing lot of from morning you must be hearing antimicrobial resistance, which is the next pandemic which is waiting to happen. More than even the UN nations had released a report that next, the antimicrobial resistance is going to lead to 10 million deaths. Okay. So, why is this happening? It is not only due to all these are indirect evidence. It's not proven, but they are proposing that slow exposure from this water, from the soil pollution, from the fishes that have consumed this antibiotic, from the chicken, from all the meat factories, whatever it is. So they're slowly entering us back. Okay, and they're causing resistance. Okay, they can alter your genetic, they can alter your gut levels. Okay, and they can cause resistance. This is especially important in some vulnerable populations like pregnant women, children, elderly, and people with renal or hepatic diseases. Okay, and even some cytotoxic drugs, like the anti-cancer drugs which we use, they can get excreted in the environment. They can come back to you. They can alter your DNA and cause subtle but long-term changes. Endocrine disturbances. Nowadays, we see a lot of infertility cases, diabetes cases, okay, thyroid cases. Okay, there is some genetic, hereditary, all the causes are obvious, but these can also, could be also, it's not very confirmatory, but these could be also leading to all these problems. And of course, there are this type B adverse reactions, which is not related very much to dose. Okay, it can trigger those also. Okay, all this which you put into the environment will slowly come back to you only. So now, what are the actions to minimize the entry and effect of drugs into the environment? What and all we starting with management, manufacturing. So nowadays in India, it is very nascent and will be seen later. So in lot of foreign countries, they have introduced something called environment risk management plans. So from production to full disposal, the manufacturing company should assess everything. That is called environment risk management. What will be done? Suppose how much is going into the environment. They should find out all that. They should do prediction. Okay. And they have to formulate a risk management strategies for that also. And even after the launch also, environment, this protocol should be updated continuously. So nowadays, what they're advocating is the use of green pharmacy. Okay? The green chemistry, the sustainable chemistry. What it means? The development of new substances that are more efficiently biodegraded but retain their effective pharmaceutical properties. I tell you, redesign of existing pharmaceuticals for environmental biodegradability. So what it means that during manufacturing, we use lot of solvents, diluents, we use lot of other materials in addition to the meat. So what nowadays they advocate is that you use greener materials for manufacturing so that they are readily biodegradable. Okay. So that is what is meant by green chemistry. One of the example is the development of glufosinamide. What is this drug? It's a green alternatively to ifosfamide. So that is 70% biodegradable and has the added benefit of improved uptake in the human. So you instead of using this ifosfamide, what is ifosfamide? Anyone? Cyclophosphamide, ifosfamide. Yes, anti-cancer drug. In that, in presence of the instead of that, you use this glufosinamide. So it retains that same action, but it is 70% biodegradable, and also there is improved uptake in the. So definitely less adverse reactions. And the use of this keto reductase, glucose dehydrogenase, halohydrin dehydrogenase, uh, dehalogenase, all these are biokatalysts. When you use it along with this atorvastatin, this hydroxyl nitrile, which is a very toxic compound, which is very hard for degradation, okay, that is avoided. So use such chemicals. So these are different modification in the mechanisms, okay, which I'm not going to read all of that. Okay, like this, lot of greener alternatives are there. So a little modification can lead to lot of environmental detrimental effects is reduced. Yes, one more thing is this benzene. It is usually not biodegradable. It is cancerogenic. Instead of that, you can use phenol, which is readily biodegradable, not cancerogenic. Okay? So like this. So this was about green chemistry. Okay, green pharmacy, green chemistry. Now coming to prescription and education. In this part is important for you. How you can do at the level of prescription, being doctors next future clinicians, how you can do this. So what you can do is practice rational prescribing. That is from morning, they must be telling you. Okay? Always do rational prescribing. Don't give antibiotics. Morning, Arvind sir also had told that rational prescription should be done. For every case of fever, don't antibiotics. Okay. Every case of diarrhea, don't give antibiotics. Okay. Rational prescribing should be done. Okay. Use medicines only when it is essential and evidence backed. Only you are sure that usage of that medicine is going to benefit only at that time you use. Avoid this empirical treatments. Next, do not over prescribe. Use the medicines only till short amount of period. Okay. Just don't write take it for 10 days, take it for 15 days, come after 1 month. Don't do that. Okay. Tell how much the patient requires, do only so much. Tailor the prescription appropriate to patient's needs. Okay, based on his age, okay, based on his gender, you should tailor the dosage appropriate. That is called personalized medicine, which is an entirely different topic. You do that one. Prescribe in small packages and for minimum duration. This already we talked about. Avoid polypharmacy. Okay, but FDCs should be used rationally. Avoid polypharmacy. What is polypharmacy? You know anyone? Usage of lot of drugs. Okay, polypharmacy means lot of drugs. If you want to see that, go to your ICU. Okay, you see how many drugs have been put. Okay, whenever they are discharging a patient, just see how many drugs they are put. Okay, many times, I'm not talking about this hospital. Generally, if you see, lot of drugs will be given. Many drugs, you don't know how they interact with each other. So all that should avoid polypharmacies. And FTCs also, there must be rational because FTC is again a double-edged sword. Okay. Because for a single disease, like for example, some dysentery, it may be caused by, usually it may be caused by bacteria, okay, or sometimes a parasite. But what we do? We give ofloxacin or nidazole. We are using two drugs. So one drug is unnecessary there. You're unnecessarily giving the patient, which is giving him an extra cost, extra adverse effect also. Okay. So FTCs must be very careful. Next is ignored part. This is very important actually. What is it? It is educating your patients. what you have to? You have to educate the patients about non-pharmacological interventions. Okay. So the problem is when the drug is getting into the environment. So you should advocate that patient is taking less drug. How you can do that? You tell them the healthy eating habit. Tell him how to be healthy so that he doesn't take in the drugs. Okay? So you advocate him healthy eating habits, physical and mental health improvement, meditation, the yoga, other lifestyle modifications, so that he is healthy and he is not taking drugs, so that they are not getting into the environment. Educate proper hygiene measures. By doing this simple hand hygiene only, lot of diseases can be avoided. Educate patients about hazards of self-medication and over-the-counter medication. Okay, this is again one more problem, because usually whenever a patient get sick, they just go to a pharmacy, buy some medicine, themselves medicate. And now, with the advent of this AI and all, people are self-medicating them more to avoid the consultation charges, all that going to hospital, all that they want to avoid. So naturally, they are self-medicating. Again, this is causing a lot of problems. So all that you can educate. So this ignorant part you must emphasize. Next, dispensing, maintaining expiry and near expiry drugs. Okay. So when there is a hospital or you set up your own clinic or something, you must always keep the policy of expiry and near expiry. Okay. When some drugs are going towards the near expiry, you must uh, you must tell your the manufacturer or vendor take back those expired drugs. Okay, so that there is rotation, discourage self medication, and again dispense appropriate number of medication. Too much, because when you go to pharmacy, you'll face this. You will tell, give me some 4 tablets of pantoprazole or something. They'll tell, sir, you cannot cut it and give it. We have to give you full extra. So what you do? You take that full packet, come to home and store it. Okay. After some days, they get expired. After expiry, what you will do? You take it, throw it in the toilet. What that will do? That will go to the water, affect everything around. Consumption, again, same, avoid self-medication, over-the-counter storage of medicines, proper segregation of medical and municipal waste must be done and disposed appropriately. The safe and proper disposal of expired, unused medicines, drugs is crucial for protecting the environment and public health. Okay, here you have to note down. Okay, at the consumption levels, please don't stock your drugs. Okay, whenever there is a disease or something, because we Indians have that habit, like we stock our coffee powder, tea powder, we'll stock our Dolo tablets, pantoprazole tablets, all the basic medicines we keep in stock. Okay, so what we do, whenever we get even a small headache, we take it off because it is already there. Many times you can do a steam bath. Okay, you can take vapor and it will go. You take rest and it will go. But what you do, because it's there, you're going to take it, and it is going into the environment. And one more problem is this: after some days they get expired. Expired, what you will do? Put it in the toilet or you put it in the drainage, that will go to the environment. So avoid that. This this is a 25th May 2025 document, okay, which was released by government of India only, and it has released a host of guidelines of how the drugs should be discarded. Okay, all this I'm not going into detail. If you want, you go back and you can search in the net for this. You can get all the instructions on how to dispose of medicines. If you are not sure about that, at least go and give it back to your pharmacy. Lot of pharmacy have this drug take back policy, so they'll take your drugs. Okay, and this is one list which is given in that same document, drugs which can be flushed down in the toilet. Okay, it is literally given like that only. For disposal by flushing by general public other than the retailer. So these drugs only you can flush into the toilet safely. Other drugs, don't put it. All this you can get it in the net. Next, coming to waste management. Is this one too much Not you guys can do, but the hospitals, okay, those can do this. Pharmaceutical industries, they can do this. What it is promoting access to sewage connection and biological sewage treatment for sanitation and hygienic reasons, which as a secondary effect would help to reduce the amount of pharmaceuticals entering the aquatic environment. Basically, what it means that you have to upgrade your wastewater treatment plants. Don't keep on using the old technology. There are a lot of technologies which has come. See, like this traditional treatment. You can see the yellow one. How much of residues? Forget the number. That is different. See the graph. How much of residues is coming out? Now you come to reverse osmosis. See, the residues are come down very much. Low residues. But the problem is again high cost. Now come here. Activated carbon. Residues have come down. Medium cost. Here residues has come down. Okay, so in all this advanced technology, the residues will come down. Okay, the thing is you have to upgrade your wastewater treatment plant, okay? Be it pharmaceutical industry, be it your hospitals. Okay. Now coming to legislative measures, this was I told you previously also. Environment risk assessment is now a regulatory requirement prior to launch of any new drug. Okay, before launching any new drug in Europe and all, you must do this environmental risk assessment. Okay, there is a ratio, there is a detailed thing, which I'm not going to in detail. You must do this risk assessment before you launch your. And United States also, you have to submit the environmental assessments must be part of a certain new drug applications. When you submit the new drug only, the environmental assessment has to be given as a part of that. Okay. Now, how is India doing towards the eco-pharmacovigilance? In India, eco-pharmacovigilance is at a very nascent stage, not supported by enough data also. Okay, strong laws are needed, but the significant things here also are there is the Ministry of Environment, Forest and Climate Change has notified specific standards for bulk drug and formulation industries to regulate and mitigate their environmental impact. Okay. The standards have been set here. It should be maintained in that standards only. On discharge also, the draft regulations in 2020 to limit antibiotic residue levels in wastewater, okay, from pharmaceutical facilities. Okay, this has also been put up in this drug regulations of 2020 and zero liquid discharge policy. Okay, this was also put up by Central Pollution Control Board to achieve zero liquid discharge, eliminating liquid waste from the manufacturing process. And you also know that our national plan of antimicrobial resistance was released in 2017, which aims to bring down the antimicrobial resistance. So, in conclusion, what I want to tell is the usage of drugs is unavoidable. It has to be done. But we must do it's the responsibility of everyone, right from manufacturing to uh, the production, the various levels of production, and the doctors, the patients, the pharmacists, the government, the hospitals. So everyone is there in this group, and everyone should do it responsibly. And whenever you prescribe a drug, just remember about these animals, okay? Because you may cause them population collapse, feminization, kidney, liver damage. Okay, so even plants are also affected. Even some more animals, frogs, fishes, all are affected. Just before prescribing, keep in mind all these animals. Just to summarize the mitigating strategies, we must use the green chemistry, biodegradable substances for manufacturing, lowering of usage. So advocate this health measures to improve the general public health. Okay, proper and do proper rational prescriptions, proper disposal, dispose it appropriately. Do not stock the medicines. And end of pipe technology is nothing but wastewater treatment. Use updated wastewater uh, treatment technologies, the new technologies you use it so that the wastes come down. Okay. So yes. So let's create a greener, cleaner world. Thanks. These are my references. Any questions?
Thank you, sir. That was an interesting and eye-opening session on the unique topic of eco-pharmacovigilance. Now, I request Dr. Sarika to please give the memento to Dr. Santosh. Now we'll take a break for tea. Be back in 15 minutes. All of you have to be back.
Students, please take the seats. We'll resume the session now.
Okay, welcome back everybody. Settle down fast. Honestly. Okay, next we will introducing Dr. M. Kavya, senior resident in the Department of Dermatology at St. Peter's. She specializes in clinical dermatology, cosmetology, trichology, and dermatology. Dr. Kavya is skilled in lasers, PRP, microneedling, chemical peels, and dermoscopy. She has presented her work at Telederm India 2023 and Cuticon in 2023 and published on topics such as topical steroid damaged face and drug induced lupus. She is an active member of IADVL and Indian Society of Teledermatology. Today she will be talking about topical trouble, a session on dermatological manifestation of ADRs. Dr. Kavya.
Thank you. Good afternoon to all here. I'm Dr. Kavya, senior resident from the Department of Dermatology. So today's topic is topical trouble, the threat of unregulated creams. So today we are going to pull back the curtain behind the unregulated cream crisis that is threatening the public health. So by the end of this session, the participants will be able to identify the common unregulated topical formulations and their risks, recognize clinical presentations of adverse reactions from the unregulated creams, and counsel patients effectively about the safe topical product use. So let's move on to a case scenario. You can see this woman, the face of this woman. Any guesses on what drug might have caused this? So she is a 48-year-old female who presented to the OPD with erythema, telangiectasia, hypertrichosis, pigmentation, atrophy, wrinkles, and hypopigmentation on the face. So what drug would have caused this? Ma'am was answering. Anyone from the audience, students? Okay, at least by the end of this session, I hope you will be able to answer this question. So over-the-counter topicals. Over-the-counter topicals refers to the topicals that you can buy without any prescriptions. The most widely used over-the-counter medications in the dermatological practice is the topical steroids. The most common complaints for which the patients use this OTC medications are acne and scars, the groin rash, dark spots and hyperpigmentation, and fairness creams. So what are these unregulated creams? The unregulated topical products are the products without any proper drug regulatory system approval, cosmetics marketed with drug-like claims, compounded formulations without any standardization, online or imported products bypassing the local regulations. The gray areas here, the gray areas here includes over-the-counter products with questionable claims, Ayurvedic or herbal preparations without any proper documentation, prescription medications which are sold without proper oversight. So, the common unregulated categories include high-potency steroids, hydroquinones, retinoids, mercury compounds, alpha-hydroxy acids, and undisclosed peptides. Combination creams, like you can see this. What is this? Katifidum. It has 5 components. What are these? One, clobetasol propionate. This is very high potent topical corticosteroid. So it has a steroid component. It has antifungal, which is the ketoconazole. It has antibacterial, which is the neomycin. So almost all, it can cure anything. Whatever may be the skin condition, you can just prescribe this and the patient will get cured. Is it? Usually the post years they prescribe this. I think so. These are the magic creams. The dermify creams, 4-derm, dermify with 5 compounds, 4-derm with 4 compounds, and each term 85. Yes, all it can cure any infection, right? Can we use this? So if we use this temporarily, yes, the patient will feel a relief. The itching will get reduced, the redness will go down, the morphology of the lesion will fade away, and the patient thinks that this is the cure for this their condition, and they keep on using it. But overuse of this, over the time, there will be development of resistance against the antifungal agent or the antibacterial agent, which are the key treatment for that condition, right? In the recent, there is an increasing number of antifungal resistant tinea infection. All credit goes to the Dermify. So hopefully, I think at least you guys, after you finish your MBBS, please don't prescribe this. Uh, the another high potency steroid, albendazole, betamethasone, abused. Um Now, what is wrong in this creams? There are no ingredients, right? These are beauty creams. They're sold uh, all over even in the beauty markets or in the pharmacies. Usually, they are used as fairness creams. They contain the steroid component and also lead or mercury, which acts as whitening agent. So, as soon as they apply, they'll feel that instant glow and fairness. But what's going to happen after applying? So let's when apply for longer time, uh, the exposure through the it can lead to both dermatological and local side effects. The dermatological side effects includes irritation and dermatitis, erythema and burning, skin thinning, and delayed healing or pigmentary changes. Systemic side effects, even this can occur. Long application of these lead-containing components like neurotoxicity, nephrotoxicity, headache, and irritability can occur. So, what is the next culprit? Hydroquinones. So, hydroquinones are also used as fairness agent. So, you can see this patient. He has blue-black pigmentation. This is due to the complication of over long-term application of skin lightening creams containing hydroquinone, right? So this is exogenous sucranosis. Long-term application of hydroquinone can cause exogenous sucranosis. So coming to the steroid side effects, I think almost you all know. Uh, it has both local and systemic side effects. When very high potent topical steroids are applied over large areas for a longer duration, it can even go systemic and cause systemic side effects like hyperglycemia or osteoporosis. Even those can The local side effects includes atrophy, which is the most common adverse effect. That is increased transparency and shininess of the skin. Face and the interdigenous regions are most commonly affected. The second one is the styly rubre, which is the visible linear scars that forms in areas of dermal damage, presumably during the mechanical stress. Steroid rosacea. If this corticosteroids are applied for a longer period on the face, rosacea-like conditions presenting with papules and pustules and telangiectasia can occur over the T area. Telangiectasia, that is abnormal dilatation of the capillary vessels and arterioles. Acne. So these topical steroids can either aggravate existing acne or induce steroid acne. This effect is due to the degeneration of the follicular epithelium, resulting in exclusion of the follicular content. Perioral dermatitis can occur. This is due to the follicular papules and pus. This is composed of follicular papules and pustules on the erythematous background that begins in the perioral distribution. Hypertrichosis can occur, hypopigmentation can occur, and there is aggravation of cutaneous infections. Not only tinea, other candidal infections like candidiasis, onychomycosis, tinea versicolor, everything can be aggravated. And tinea incognito. So this term was coined to describe the marked tinea infections that was transformed into unrecognizable cutaneous eruption. Like I said, the morphology of the lesion will get changed. And the corticosteroid therapy suppresses the inflammation while the fungal growth flourishes. So you can see here the classic morphology, which is the annular plot, is altered, and it will either result in like post-inflammatory pigmentary like lesion. It's difficult even for us to find if the original primary lesion is tinea. So then the granuloma gluteal infantum. This is the consequence of dermatitis that is being treated with corticosteroids. So there will be persistent reddish purple granulomatous or papulonodular eruption that occurs on the buttock or in the thigh region or in the intergluteal fold in children. Tachyphylaxis can occur. That is, the efficacy of the corticosteroids will be decreased during continued treatment. Topical steroid addiction or rebound syndrome can occur. This is characterized by an initial improvement and then lack of response after continued application and flare after the withdrawal of it. And this is the answer for the first question. So she has this topical steroid damaged face. This is due to extensive and uncontrolled use of topical steroids. So there will be complex signs and symptoms that occurs as a result of chronic misuse or overuse of the topical corticosteroid agents. The most common features include telangiectasia, dryness, facial hypertrichosis, acneiform eruptions, pustules, or cutaneous atrophy. So this TSDF needs early identification before it becomes an irreversible condition. So the next, retina. The usage of retinas has bloomed after the bloom of Instagram. So the most common adverse effect here is the retinal dermatitis. That will be irritation, erythema, peeling, and burning or pruritus. Increased tolerance to the UV radiation, which results in photosensitivity reaction. And of course, these retinoids should not be used in pregnancy and lactation and also in hypersensitivity reactions. The topical salicylic acid. So here you can see some ulcers. Why has it happened? This patient has overused over the counter of high percentage of salicylic acid, which is applied more frequently for the treatment of wart or corn without any medical supervision, and he has developed ulcer. So the take-home message is that corticosteroid containing cosmetic creams should be used by patient that is used by the patient has to be regulated. Patient education on side effects of long-term unsupervised use of the steroids need to be done while prescribing the topical steroids. A check on over-the-counter sale of topical corticosteroids, retinoids, and hydroquinone will also help combat this issue. The misuse and damage have serious effects on the quality of life of these patients. So please say no to over-the-counter fairness creams and also to the magic creams aiming instant.
Thank you, Dr. Kavya. I now, it was an enlightening session. I now call upon Dr. Sujata ma'am to give a mentor to Dr. Kavya. Our next speaker is Dr. Adira Mohandas, Assistant Professor in the Department of Pharmacology at St. Peter's. She completed her MBBS from MRC and MD Pharmacology in Medical Sciences. Dr. Atira has previously worked as a regional medical advisor for known authors and has presented papers at multiple national conferences. Her key research areas include pharmacovigilance, vigilance, and clinical research. The topic today is Beyond the Leaf, a talk on areas related to herbal products.
Good evening, everyone. Yes, this is the last session. So, this is going to be just for information. So, here it is not into the real subject of pharmacovigilance. This is for your knowledge, this is for your awareness. So, this is about herbal medications. So, when you look at this picture, so what do you see? You see something like a herbal capsule. Okay. So, herbal capsule. So, what is the first impression that comes to you? Yes? About? Yeah. So generally, what people feel is this herbal medications are free of side effects, they're very safe, and they can be used without any adverse effects. Why? Because they are all natural. They are from the leaf. So after all, what harm can a leaf cause? So today I'll be talking about something which is beyond the leaf. So we'll be talking about the challenges in monitoring the safety and adverse effects associated with unregulated herbal medicine use. So, when you look at the global herbal market, so this is not a tiny market, it is a multi-billionaire market. You can see almost close to 50% of this market is led by Western herbs. Western herbs are the herbs that is traditional medicines that is used in US and Europe, then followed by the traditional Chinese medicine, homeopathy, and Ayurveda. So the main, this is the main components of the global herbal market. And when we talk about the herbal market, they can be herbal medications or they can be food supplements, the dietary supplements. So when comparing between the herbal medications and the dietary supplements, the herbal dietary supplements will have a uh, comparatively more market when compared to the herbal medications. So when you look at the global herbal supplement market, from 2024 to 2030, if you see, it is raising from $87 billion to more than $140 billion. So it is increasing. The growth rate is more than 6% per year. When you look at the situation in India also the same thing. From 2024 to 2023, in 10 years, the market is it is going beyond triple, beyond three times the growth rate is. So there is a huge revenue that has been uh, derived from this herbal market. So when there is such a rapid growth, so we have to also know about how safe is these drugs. So why there is so much of popularity for this herbal medications? The main reason is the perception of natural being safe. So we know there are a lot of things which is natural. Even there are many poisons which are natural, but they are not safe. So this perception, when the common public they perceive these drugs to be safe, so they often do not associate any adverse effect that is occurring because of the herbal medication to the drug, because for them these are just herbs, so they are very natural and very safe. And adding to this perception, there is a long history of traditional use. So they have been used for so many years. There is no problem with using these herbs. Culturally, it is accepted. It is easily accessible. Even online, also you can get without any prescription. It is cost effective. It is less costly when compared to the allopathic medications or the conventional medicines. It has been found that 80% of Asian and African population rely on these herbal medications as a primary health care. So that much ingrained is the problem of the unregulated use of herbal medications. So there are a lot of safety concerns. So now we have seen that there is a lot of revenue that has been gained from this herbal medicine, the the industry of herbal medicines, and there's a lot of popularity. Now, when we look into the safety, do we have enough regulations that is that can control the use of or that can look into is there any strict rules where these herbal medications that come into market is safe? Are there actual toxicity studies? Are there good preclinical clinical data, RCTs to prove that these drugs are good? So there is a gap here. There are no strict regulations on these herbal medications, and once they're into market, there are many uh, producers which are not licensed, and they bring them into market, and after they are into market also there is no proper reporting of adverse effects. There is lack of safety monitoring of these herbal medications, and there is an inconsistent quality control. There is because of the lack of the good manufacturing practice, good laboratory practice, their quality control is also very inconsistent. There is adulterations. These herbal medications can be adulterated with few pharmaceutical agents. There is a lot of cases where this traces of NSA were found in these medications, which were herbal. And also there is cases of heavy metal adulteration, heavy metal poisoning, heavy metal traces were found in these herbal medications. Then there is variable potency and composition. That is, even though these the same plant, they will be found, they'll be from the same genus, but the species will be different. When the species is different, the potency is different, their composition is different, and also it depends on from which part of the plant the drug is being extracted from. The composition which is there in these seeds will not be the same which is there in the, so some part of the potency will be more. So there is variable potency and composition even within the same plant. Then there are a lot of self-medications. That is because there is no strict regulations for this. People take it over the counter, and they do not follow the proper dosing. There is incorrect dosing, and because these are natural, they feel how much of it they take, it's better for them. It's good. Then there is a lot of cases of drug-herb interactions. When these herbal medications are used along with your conventional drugs, along with your prescription medications. There are a lot of drug interactions which occur that way. And when even if they report an adverse effect, HCPs will not be trained enough about this herbal medications to guide about this was the to guide them about how to report, or there is no clear idea about how to report an adverse effect that is occurring due to the herbal medications. There is a lot of underreporting of adverse effects. So when we come to the clinical consequences, the risk factors, adverse effects, it can range from milder GI discomfort, altered drug levels of the concomitant drug given, this sedation, hypotension, hypoglycemia. It can even cause life-threatening conditions like bleeding, organ rejection when these herbs are used along with any immunosuppressants. So in patients who are post-transplant patients, there can be organ rejection and even death. So these are few cases of reported toxicities with herbal products. So the toxicities, the herbal drugs can affect different systems. It can affect your cardiovascular. Most commonly, hepatotoxicity and renal toxicity is found with many herbal medications. It can affect cardiovascular, the neurological, hematological, and the diagnosis of this adverse effect is mainly depending on the time. So the causality is being determined like that, but most of the time the causality is not very clear. It is unclear. So there are few reported cases in 1992. Aristolochia, which is a drug used for weight loss, caused renal failure in a lot of number of patients. 1995, another herbal medicine caused an outbreak of obstructive lung disease. And in 2007, a Swiss survey was done on Herbalife. Herbalife, I hope many of you would be aware of this. So Herbalife was a herbal medicine which was promoted for weight loss and well-being. So there was more than 10 cases of reported severe hepatotoxicity. But there also, the causality was not very clear. There were a few other cases of reported toxicity, like with licorice, ephedra. Ephedra was very commonly used, and in 2003, because of the symptom-limiting side effects of ephedra, it was withdrawn from the market. Then we have other interactions and other drugs causing this garlic, ginkgo biloba. Ginkgo biloba, if you have heard, you must have heard, it is a cognition enhancer. It increases the risk of bleeding. Then St. John's wort, which is used for depression, it is a strong inducer of CYP enzyme, so it can cause drug interactions also. So coming to a case report of organ toxicity. So this was a case report of ashwagandha-induced liver injury. So 22-year-old male from Poland was admitted to the Department of Gastroenterology due to jaundice that appeared few days prior. The patient reported pruritus, malaise, fatigue, GI discomfort, and stool discoloration. He was not under any regular medication. He has been recently consuming ashwagandha. The duration and the dose is not clear. And the lab investigations were done. It found there was a markedly elevated bilirubin level, ALT elevated. But that is an autoimmune process of hepatitis and other things were all ruled out. Our ratio, the ratio for the value calculation for to find out which type of liver injury it is. So if the value is between 2 to 5, it is liver disease, then mixed, and if it is more than 5, it is hepatocellular kind of damage. There is a specific ROCAM scoring which is done for, it is a causality assessment for diagnosing liver caused by drugs. Here they look into the parameters of the time of onset of the reaction, the course, the risk factors. Each parameter will have a scoring. And if scoring is more than 5, then they diagnose it as a drug-induced liver injury. So after 3 months of treatment and stopping ashwagandha, the liver test returned to normal and the patient condition improved. And the diagnosis was ashwagandha-induced liver injury, which is of hepatocellular. So when these most of these herbal drugs, they are not a single content, they will be a mixture. They will be mixture. So it is difficult to identify the exact cause, which component has caused this liver injury. It's difficult to identify. So there is a need for a mandatory testing of the individual supplement, and each ingredient in the herbal medicine should be tested individually so that there is no very serious adverse effects. So from the previous few studies, it was found that ashwagandha is a potential hepatotoxic agent. So whenever a clinician gets a patient taking herbal medications, he should find out whether it is any of the hepatotoxic drugs like ashwagandha. Herbal medicine toxicity diagnosis is very complicated. Uh, because it is not just the causality. We have to also look at the genetic factors. If it is in polymorphism of the gene that is responsible for this drug metabolism enzyme, if that is the cause, and all this, so these all things make it difficult to diagnose in herbal medicine toxicity. Now coming to herb drug interactions. Till now we have seen the drug itself causing a hepatotoxicity or any kind of toxicity. So it is an intrinsic toxicity caused by herbal drugs. Now this is a combination. It is herb drug interaction, and there is another type of adverse effects where there is extrinsic. Extrinsic means where the drug is adulterated or whether there is a mislabeling. So some other outside causing adverse effects. So coming to the herb drug interaction. So this is a study of 46 systematic reviews, 46 cases of the herb drug interactions. So it was found that the most common drugs that was uh, uh, the most common cases where the drug classes that involved in this herb drug interaction was anticoagulants, cardiovascular drugs, immunosuppressants. All these drugs were the one which is commonly part of this herb drug interaction. So the mechanism of this herb drug interaction can be the interaction based on the pharmacokinetic side, or the mechanism can be pharmacodynamic. Pharmacokinetic side, we know absorption, distribution, metabolism. So any impaired absorption, if the herb contains something which, like fibers, gums, or mucilage, so where it impairs the absorption of the concomitant drug, the prescription drug, so there is an interaction there. Then distribution, metabolism. So some of the herbs, like the previous slide we have seen, the St. John's wort, which will inhibit cytochrome P450 enzyme, which will inhibit P-glycoprotein, the transporters. So this will affect the efficacy of the concomitantly administered drug. Then some of the herbal medications can displace prescription medicine from the site of binding at the proteins, and then excretion. Some herbs can change the renal clearance, so the drug which is taken will not be properly excreted. Then you have interactions on the pharmacodynamic side where the herbs can have an additive, synergistic, or an antagonistic action as compared to the concomitant drugs. So which occurs at the organ system, receptor, or the enzyme level. So, whatever the evidence that we have about this herb drug interactions are mainly from the case reports, case series, and the studies are very limited. We do not have many studies. It is difficult to assess the variability in herbal product composition because it is always a mixture. Then there are two types of mechanisms responsible for this herb drug interaction we have already seen. Then these are few examples of herb drug interaction. So this Centron's wort is one herb, which is herbal medicine, which when used with cyclosporin, because of its injection of the cytochrome P450 enzyme, it can cause renal transplant rejection when the patient is on immunosuppressants. Then warfarin plus juvobilaba can cause intracranial hemorrhage. And few other examples, green tea, which can interact with warfarin, it can interact with venous stimulants and antihypertensives. These are few examples of herb drug interactions. So in this you can see uh, the St. John's wort, which we have already seen, it will reduce the level of cyclosporin, so it can cause transplant rejection in patients who are on this cyclosporin. OCP failure can occur. Then Citronella phenium graceful, it is nothing but a fenugreek. So fenugreek has an synergistic action with antidiabetics, so it can cause hypoglycemia. Then allium sativa, that is garlic, has a synergistic action with this antidiabetics, so that also can lower the blood glucose below. It can cause hypoglycemia. So these are a few challenges that we encounter with herbal medicine. So there are limited studies on the adverse effects and toxicity, and no standardized safety monitoring nomenclature, and there are no strong regulations about these herbal medications that come into market. And there is also quality control issues like contamination. There is no proper good manufacturing practice that is being conducted, or good laboratory practices are not being followed. So there is contamination. Contamination can be with the pesticides, or it can be with the microbial contamination. There can be adulteration, like how I have mentioned before. There can be traces of the pharmaceutical products inside these herbal medications. And mislabeling. Sometimes the labels will not be clear. What is written outside will not be the actual content inside. And also the mislabeling in terms of the same plant will have a different species, the genus will be the same. So the efficacy, the potency, everything will be different. and there is lack of good manufacturing practice, uh, good agriculture practice, good laboratory practice, and proper pharmacokinetic and toxicological data is also lacking in case of this herbal medication. So there was a case of this heavy metal contamination. A Australian woman aged 34 years. So she was presented with progressive shortness of breath, palpitation, arthralgia over 1 month. So her hemoglobin was found to be 6. Lead level was 105 micrograms, and there was a low level of mercury. There were traces of low level of mercury also found in the blood and also arsenic. So the patient reported that in the past 6 months, she had consumed multiple herbal drugs for fertility enhancement. So this herbal preparation analysis confirmed that that herbal preparation contained lead and mercury. So this is a case of heavy metal poisoning that is seen with herbal medication. And there is a lot of underreporting of adverse effects. The one reason for underreporting of adverse effects is patients perceive that there is a perception that these drugs are safe, so they do not link it to the adverse effects. Then ADR reporting system was not very proper. Earlier, it was not properly conducted for the herbal medications. Now we have solutions for that. Then users do not disclose that they are using a herbal medication to their physician. They do not disclose it to their medication, or the concomitant use of this prescription medicine along with the herbal medicines is not disclosed to the patients, to the physicians, and even the clinicians. They fail to ask if they are on any herbal medications. And there is an unwillingness. Nobody knows whether this herbal medication is the actual reason for this reaction or not. So they do not report it just based on suspicion, and many do not know how to report. So these are the regulatory aspects of herbal medications in India. So the Drug and Cosmetic Act 1940 and Rules 1945 govern herbal medicines by the Department of Ayush. So manufacturing license is required to make or market herbal medications. The Drug and Cosmetic Act ensures that the manufacturer or whoever is exporting them, they should have a GMP license. And this Ministry of Ayush has now concentrated on development of Ayush healthcare system, and it oversees the Indian herbal drug regulation. When we look into the regulation all over the world, there is harmonization. Each country follow a different regulation for herbal drugs. So in UK, there's a traditional herb registration certificate that marks the product to be exclusively based on long-term use. So in UK and Europe, they have a traditional herb registration certificate which will be labeled on the herbal medicine. So that shows that the drug was used for more than 15 years in Europe, more than 30 years in UK, and is safe to be used. In US FDA do not conduct any surveillance on this herbal medications. And many national drug regulatory authorities lack the proper knowledge of herbal. That's why WHO is trying to uh, bring common regulatory, trying to have a common rules or a uniform pattern for all the countries. So, what is the way forward recommendation is we need regulations which is distinct from food and drugs. So in many parts of the world, many herbal medications are being marketed as dietary supplements. So when they are marketed as dietary supplements, they do not have to go through all these regulatory hurdles of a medicine. So, but again, these herbal medications, they are also equally effective, like in and their effectiveness is not very clear. So they also need some regulations. That pre-market authorization, proper preclinical studies and RCTs and clinical studies are required. Then licensing of the manufacturers with GMP uh, has to be there. And now we have WHO, RCH, IRCH for global cooperation and safety. And clinicians should routinely ask and document the herbal use, educate the patients, and nurses and pharmacists also. They can also counsel the patients about this herbal use. So this WHO's IRCH is an international regulatory corporation for herbal medicines. So there are close to 47 countries who are a member of this IRCH. So recently in India, on August 6th, last month, they had conducted a 3-day workshop. So along with Ministry of Ayush and WHO, they conducted this WHO IRCH workshop in Ghaziabad. So there they launched this Ayush Suraksha, which is an pharmacovigilance for herbal medication. It's an online portal. So Ayush Suraksha is an Ayush base. In line like it is the same like pharmacovigilance program in India for our for the therapeutic medication. The same Ayush Suraksha is for the herbal medication. So adverse drug reactions are reported from all over the country. They have one national pharmacovigilance center, which is in All India Institute of Ayurveda in Delhi. Then they have five intermediary, intermediary pharmacovigilance centers, and they have 97 periphery pharmacovigilance centers. So it is it's like PVPA. They will get from the periphery to the intermediate and then to the then when I took yesterday, the number of ADRs was 106, and the number of OAs and MLAs is it is unacceptable. It is like some advertisements which is not appropriate, inappropriate advertisements. If you see any inappropriate advertisements about any herbal medications or any claims that is not true, you can report it to this Ayush Suraksha. So, for strengthening and safety of herbal medicines, we should have a national regional based database should be there. For this, first reporting has to happen, and then we have to develop this database on herbal medications. Educate healthcare professionals and patients on the safe use of herbal medications. Recognize traditional medicines as contributors of primary care and drug discovery. Definitely, these traditional medicines have a role, but we have to see what are the adverse effects and how it can be used in an effective way. So, immediate priority is to enhance the patient-physician communication on herbal use. It should be made into a practice that clinicians ask your patients about any herbal medication use. Then increase healthcare professional awareness of about herb drug interactions. Whenever they are prescribing drugs, which are most commonly there is more cases of herb drug interaction like anticoagulants, immunosuppressants. So whenever they are prescribing such drugs, they should always ask a history of any herbal. Encourage physicians to routinely ask patients about herbal use, strengthen surveillance of herbal medications related to adverse effects. So, and also promote preclinical and clinical studies, and also strengthen the government regulatory efforts. So, in conclusion, like all drugs are capable of producing adverse effects. So, whenever a drug is given, a risk has been taken. The magnitude of the risk has to be matching with the therapeutic effect. So, see, like if you take for chemotherapy drug, there's a lot of adverse effects, but the efficacy is that therapeutic the benefit is that much, so we can bear with the adverse effects. So, when there is takedown in the therapeutic then why should we go through this adverse effects? So the first in the use of herbal medication globally, safety and efficacy of herbal medication have become a public health concern. Major problem is with the use of herb-based treatment is a lack of definite and complete information about the composition of these extracts, resulting mainly from the trade secrecy. So they do not disclose what is the content. So clinicians should take a detailed history of herbal use, begin with drugs that commonly cause herb drug interactions, and educate patients about the possible risks. So this was a uh, thought that came into my mind. Like when there are strict regulations on herbal medications, it can stop the innovations and reduce the access to traditional medicines. Uh, but at the same time, it is necessary to protect our public health from the adverse effects. What are your thoughts on this? You can think about it, or you can. We will give you the mic. You can. So here, I'll go back to my first slide. So here, these capsules are actually turmeric capsules. I don't know how many of you know that these are turmeric capsules is currently in market. So they say that turmeric has a lot of antioxidant properties. It is very good for your health. So turmeric, when it is mixed with pepper, so turmeric has a low bioavailability. So to enhance the bioavailability, it is mixed with pepper and is given in capsules. So, but when you look into the case reports, the most common cause of adverse effect, drug-induced adverse effects of hepatotoxicity is with turmeric. So, how much do you need this turmeric in capsules, or are we sufficient with the turmerics in our curries? That we have to decide. Thank you. Any questions?
Thank you, Adira. That was a very informative and enlightening session. So I would request Dr. Arvind sir to please give the memento to Adira. So that was our last session. So we would like to thank the management, the esteemed dean of the college, medical superintendent, and vice principal, the esteemed colleagues, the delegates, participants, students, all of you for your participation and support. I would especially like to thank my colleagues, the members of organizing committee for their efforts for making this program a success. So we had conducted a webinar on 18th of September. So we HOD sir to give away the mementos to the participants, the speakers of the webinar. Dr. Poviri, Professor, Department of Pharmacology. Next, Dr. Yorani, Senior Resident, Department of Pharmacology. Thank you, sir.
Finally, this brings to the last stage. This year, we have celebrated the National Pharmacovigilance Week from Department of Pharmacology. So I would like to thank everyone. So I would like to thank the management and our secretary ma'am, then our dean sir, VP sir, MS sir, and all our colleagues. And most importantly, these programs we could not have done the support of our colleagues. All the colleagues of my department, they are the backbone for the success of this program, without whom we could not have done. Thank you. And last, not to forget the participation of the students. So without the students who could not have done, thank you one and all.
Last, please stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, sir. Thank you very much. Thank you, sir.
Sir, meeting close பண்ணிடுவாங்க சார். Meeting. Zoom meeting. Yes, sir. So, thank you everyone.